I will tell you that in 2022 through 2023, they leaned very hard on me to be quiet. I mean, to the point where a president of the society showed up at my home.
That's scary.
Yeah. So, yep.
Like threatening?
No, in a very nice way.
And how did that go?
That went well. Yeah. I know bullying when I feel it. I literally was in the kitchen on purpose with the roof leaking into a bucket. And this man who walked in the door with a bottle of champagne. And I'm like, you don't know your audience. Like, I'm all in. I've emptied my bank accounts and you're bringing me a bottle of champagne telling me to be quiet? Like, this is not resonating. And that was one of those moments where, am I someone who's going to just back down because I'm scared? Or, you know, am I that girl from Georgia who just goes, okay, well, I know it's right. I know it's true. So come at me.
Dr. Elizabeth Potter is a board-certified plastic and reconstructive surgeon, nationally recognized for her expertise in microsurgical natural tissue breast reconstruction. But her resume extends well beyond the OR. She's an outspoken patient rights advocate who helped spearhead the push for a dedicated billing code. A billing or CPT code is like a barcode for a surgery. If that barcode exists, insurance can scan it and pay. Essentially, she ensured that women wouldn't lose access to this state-of-the-art procedure. You might also know Dr. Potter from the viral story earlier this year where United Healthcare allegedly called her while in the OR mid-surgery to grill her about a cancer patient's overnight stay. She stepped out of the operation to defend the patient's case, posted the story to her Instagram, and suddenly millions of people got a front row seat to the bureaucratic madness doctors wrestle with every day. So today we're going to dive into how a single billing code can decide whether a woman can access state-of-the-art treatment, what happened in the aftermath of that now famous United Healthcare call, and why it really matters for all of us, and the evolving ethics of profit versus patient care when scalpel meets the spreadsheet. Let's get started with the Checkup podcast featuring Elizabeth Potter.
Starting from the beginning of your career, how did you end up practicing where you are today?
Okay, so in Austin, I always had my eye on Austin. I thought it would be a place where, like, as a woman, I would have independence. I don't know why I had that feeling, but growing up in Georgia, I identified Austin as a place where I could be, like, I don't know, like, open and in power.
Okay. Was that
strange,
movie influence, personal influence? How did that?
No, I remember, honestly, I think it had a lot to do with sports.
Interesting. Okay.
And then also just learning about, like, the West. And I had this feeling about women in the West, that they were strong and independent. And that was probably, like, influenced by things like movies and stories. But I'd never been to Texas. But so, when I was in medical school, I saw a mastectomy. And I saw the reconstruction as they were finishing, and I fell in love with it. So I'd never seen that before. And
if I'm a person that's never heard of the procedure, how would you describe it to me?
Yeah. So when a woman has breast cancer and has a mastectomy or has her breast removed, there are surgeries to reconstruct the breast. And those are actually covered by insurance under the Women's Health and Cancer Rights Act of 1998. And you can reconstruct that with an implant or with natural tissue. So I saw a surgery where they used a woman's own tissue to make her breast. Like, she went to sleep, had mastectomies, woke up with a breast made out of her own, like, tummy tissue. And it just, a lot of things clicked for me, seeing that. Being a woman, body image issues, my grandfather had lost his legs, losing, there was just a lot that just really resonated. And I leaned in and went straight for breast reconstruction.
That's a long journey that you were eyeing for yourself, because that's not a quick path, right?
No. So I went, finished med school at Emory, and then
4 years.
4 years. Then plastic surgery at Southwestern, and that was
5 years.
5 years.
5 years.
Yeah. And then another year of fellowship at MD Anderson. So let's see, Emory Med. Then that's a lot of years.
Yeah. And the main passion for you from that case What sticks out about that patient? Was it your conversations with the patient, just watching the surgery take place, like the skill set required to perform the procedure? What did you see that motivated you to connect so strongly with the field?
I think it was, so I felt this feeling in the operating room where it felt very controlled and like harmonious. It was like a zone. I felt that I was in the zone. Yeah, I was in a flow state. Even as a medical student, something was like the bells were ringing and the birds were singing. And I'm like, something is special here. But it was really rounding on that patient afterwards. So she had traveled from the West Coast to Atlanta to have that surgery. And even back then, I was very impressed by how hard it was for women to get healthcare and to get the kinds of healthcare that they wanted, like the surgery she chose, and how much trust she placed in the surgeon performing that surgery.
Why did she have to travel so far? Is it not uniformly available to?
No, even back then, it just wasn't very common. Still today, it's not. Like, there's not a lot of folks like me around. There's maybe like 200 microsurgeons in the country who do breast reconstruction a lot. So it's not an easy surgery.
Is it lack of training spots, interest? What is causing the limitation?
That's a great question. I'd say it's a lot of different things. Plastic surgery, the folks who go into plastic surgery, the majority of plastic surgeons do cosmetic surgery.
Fair.
Yeah. And there are many reasons why breast reconstruction isn't broadly available. One of them is reimbursement. And so any plastic surgeon has a skill set leaving training that they can make a lot of money with. And
because they could monetize directly to the consumer and don't have to deal with any of the administrative burden of working with an insurance company, hospital administrators, et cetera. Is that a fair understanding?
Yeah, and they can set their price. And
Right.
the reimbursement for breast reconstruction is painfully low. And we've fought that. But I mean, I think that a lot of plastic surgeons just look at it and go, it's not worth my time. And I sort of set out from the beginning to create a case for breast reconstruction. Like before any of this happened, I said, I'm going to show that this is a viable career path so that other surgeons like me who love the work will follow through and do this with excellence, not just do it for 1 or 2 years as they're starting to build up their client base for their cosmetic practice.
Right.
Right?
Yeah, because I see a tremendous similarity in the through line of what you're describing with breast reconstruction and plastic surgery, along with psychiatry and psychologists. So when I'm trying to get mental health access for my patients, which is quite often being a primary care doctor, the people who are good or who are most experienced require cash payments up front, usually large sum. And then the ones that do accept Medicare, Medicaid, some of the simpler insurers that have a tough time with reimbursements, they're not taking patients, or there's a 6-month wait, or they're falling in and out of plans. So I'm basically putting this impetus on my patient who is already in a dark mental place, lacking motivation, to say, hey, get motivated, call 10 places, get rejected from 5 of them. 1 will cancel on you. And the one that you do end up seeing, if you don't like them after the first visit, you have to do that process all over again.
Welcome to healthcare.
Similar trajectory of the field moving away from what its intended path was to where the incentives led them.
Absolutely.
The financial incentives, if we're being honest about it.
And also just the system,
the
way the system's built. I mean, it's gotten more and more cumbersome for doctors to practice within the insurance system, even if they want to, even if the reimbursement's good.
Yeah.
You know, just the overhead of doing that and how hard it is to jump through hoops. And so I think that there's a lot of similarities there. For me, it's, a cancer patient who's already, they're so down and out.
Right.
They have no extra energy to fight a fight to get breast reconstruction. If you put up an obstacle in their path, they're probably just not going to get it. They're just going to have a mastectomy and fight that fight another day, or maybe not have reconstruction. So I really wanted to demonstrate that this could be done honorably and fairly and like with excellent outcomes. And I was on that path, like full steam ahead doing that. I even built my own surgery center.
Wow.
Where I was like, took out personal loans, right? And built that myself to say, I can do this surgery in an outpatient setting and save money and have better outcomes and have a better experience for women affected by breast cancer. And I was like full steam doing that and trying to negotiate with insurance companies to be in network with that.
Yeah.
And then all of the other happened too.
Well, I applaud you for doing that, because most doctors, largely how complex the system is, are afraid for one reason or another to go and be that trailblazer. And without trailblazers like yourself, we won't see change happen. So I think that is one of the most important things that you're doing. And we actually have a similar relationship with a psychologist and psychiatry group that is trying to do the same in New York, where they're opening up a huge practice in order to accept patients who have lower forms of insurance.
Totally.
And use it as a viable path, hopefully to motivate others. And they reached out to us, and ironically, the person starting it was a med student that shadowed me when I was in my residency program. And he said, can you recommend from like a financial standpoint, what alternative monetization pathways can we create so that it sort of acts as a funding to actually take care of these patients? Because the insurers are not subsidizing and paying for the care that we're giving the patients. We have to be unique or think outside of the box to actually turn a profit. And that's so ridiculous that has to happen. What strategies did you use in order to fill that gap or subsidize the care so that everyone's getting good quality care, but you're still having a viable business plan?
That's a great question. And it's one that I'm still working out. I think for the first many years of my practice, I just played the karma card.
Okay.
And I really
that
just
if you
said,
do the right thing, it'll come back.
Yeah.
Fair.
I did. And
we did the same thing on this channel, by the way.
Right.
So,
yeah. So, and I'm like, I was in my late 30s, early 40s, and I'm like, I just know it's going to work out. And I've never met someone as, committed to this as I am, and I'm just going to do the right thing, and the world is going to see that. And I would use the money that, if a case paid me better, I would do the other case for free. And I never turned anyone away, Medicaid, Medicare, TRICARE, all of it. I never have. And I tried to negotiate with insurance companies to get better payments, and that was just impossible.
Was it you doing it as an individual, or did you have a group of local people that you were working with in the same specialty?
I hired consultants and paid a lot of money to do that. And, it's so frustrating, how this works, that in the same zip code, like I can find out what other doctors are paid for the same surgery that I'm doing, and I'm underpaid in my zip code, and they just don't. They don't.
And is
care.
that because you're out of network, or what's leading you to be paid less than them?
I'm in network for everything.
So then what is the reason for the disparity?
It's just so there's no transparency.
So how are you able to find out?
Fairhealth.gov.
And when you're finding that out, do you have a reason why they're earning different sums for reimbursements?
No. And that's still quite an important question that all doctors need to be asking. Like, why is it that in the same zip code that a doctor, maybe even with less experience than I have, is paid 30% more than I am?
Is it due to a bargaining power of a group that they're part of?
It seems arbitrary almost. But certainly what we're learning is that with more consolidation of groups, that those groups get better rates and the facilities and all of that. And that's part of the...
Well, that's why a lot of the solo practice offices are closing left, right, and center, even in primary care.
Yeah.
The idea of a family medicine doctor having their own practice doesn't really exist anymore. It's all group practices, largely because of the administrative burden required to do the negotiating, to do the arguing, the billing, the coding. And it takes the doctor's focus away from the art and science of practicing medicine, and instead puts more emphasis on the art and science of making sure your notes are good and making sure you can negotiate and upcode liberally.
Yeah. So my dad was a doctor. I grew up, he was an allergist in a small town. So I grew up around medicine. My mom was a nurse. And I really think that what you're describing is a phenomenon that's happened, in the last 15 years. It's really been since the Affordable Care Act and the vertical integration and consolidation in medicine. And before the Affordable Care Act, 75% of physicians were self-employed. And now 75% of physicians are employed by large entities. And we're losing that personal aspect. We're losing the magic of medicine, where no matter what decision I'm always going to be like thinking about the best health of my patient, right? I don't have a fiduciary responsibility to shareholders in my practice to maximize the income from this encounter. But when you have huge companies now controlling the strings, we've seen this experiment for 15 years and we're living the result. And we actually, it doesn't just feel wrong. We now have data to say it doesn't work. Vertical integration isn't helping us take better care of patients. It's not making more equitable, health policies. It's not even decreasing the price per capita. All the things that they said it would do, it's not doing.
Right.
So
it's increasing profits.
Oh, yes.
And creating multi-billion-dollar businesses.
Right. And then these huge industries that, are paying themselves. Right. So the whole fact that
we should probably also jump in because I know what you're talking about with horizontal versus vertical integration. You have companies from a horizontal standpoint. Let's say one pharmacy is taking over a branch of other pharmacies. That's considered horizontal. But then you also have vertical consolidation where you have an insurer buying a pharmacy, buying a PBM, buying a medical practice, and then essentially doctors.
Yeah.
And that vertical consolidation ends up becoming harmful largely because of the lack of competition. They essentially start squeezing out their competition through financial pressure, through poor agreements in bargaining, and it's a mess. And where I've seen it be the worst type of mess, where it's so clear that it's unethical, is in the PBM world. These pharmacy benefit managers that were initially started as a way to save us money, and that was the premise that was sold to us as the public, and we were like, cheers, yay, they're going to save us money per prescription. And then it started being a business where they said, okay, if we save you $2, we'll take $1. And then through vertical consolidation, they became part of the problem, essentially fake saving you money, but essentially making money for themselves, where they're now worth billions of dollars.
Correct.
The company that, to put an analogy that most people understand, the coupon company has become $1 billion company.
And that's not regulated. No transparency, and none of the federal regulations that apply to the insurance company, the mother company, apply to that company. Yeah. So, I mean, I think to add to that, there's also this sort of 85-15 rule that was interjected with the ACA. Simply, an insurance company is supposed to spend 85% of premiums on healthcare and quality improvement. So like on taking care of you. Right. And that other 15% goes to wherever they want it to go. If it's to shareholders or CEOs or whatever. So one of the ways that vertical integration has been gamed is that they're now paying themselves, right? So to get into that 85%, they can say, okay, the cost of this drug is part of the cost of care for the patient. But they're actually just moving money from the right pocket to the left pocket.
Yeah, exactly.
Right, so it's cost, but they never left the bank.
Yeah.
And all the while, if they can make the whole pizza bigger, the whole pie bigger, then that 15% on the top, that's how you get someone, at United who's making $64 million this year. Because if you can make the whole pie bigger, then that 15% is sweet. And the rest of us have to deal with the fact that we've just increased the cost of healthcare to make them more money.
Right. And that cost is sometimes hidden pretty well because they'll move it around from your monthly premium to your deductible to your copay. And you might say, oh, well, my annual amount that I'm spending on the monthly premium isn't that much different. Yeah, but now you're paying double the amount when you go see the doctor. Now, when you have a major surgery, the cost that you have to incur on your own is much higher. And when they do that, they create really good press hits surrounding it, where they say, well, look, premiums didn't go up. Well, what about all the other things that you've packaged into it?
Correct.
And I see that not just as a physician, but probably I learned more about it running a small business in paying insurance for the employees of our company, where I look at the costs, I'm like, oh my God, how do people afford this?
Yeah.
The cost has become absolutely astronomical. And I'm curious how that plays into you running your business and how it changes the way you take care of your patients.
Gosh. Okay. So, I mean, at the heart of it, I'd always try to just do the right thing. I mean, I do. And that's where I'm not trying to game the business and I'm not trying to make more and more money, but
you're trying to do the right thing health-wise for your patients.
Right.
Versus some of these private equity owned industries are thinking about the profits, and the doctors and the clinicians are thinking about the patients.
Totally.
And it creates this
tension
that even, I don't know if you watch the show The Pit on HBO. You see that where,
such a great show.
He's saying, we're taking care of patients. We're doing the best we can. It's like, you need to increase satisfaction. You need to increase the amount of patients seen per hour. And it's like, well, do you want us to deliver good care or do you want us to see more patients?
Listen, do we want more money and higher throughput, or do we want quality?
Right.
And we just haven't decided as a country what we're going after.
Right.
We spent the last 15 years going after, money and numbers.
Yeah.
Right. How do we get more efficient? How do we see more patients? How do we do more cases in a day? And it's just demoralizing. And that's where all of that, that moral injury for a physician comes into play. Yeah. Even talking with physicians who work as within insurance companies, doing peer-to-peers. So I've had some private conversations with folks doing that, and they say that's exactly what it is. It's like, I have to do 20 of these a day, and I'm only judged on how quickly and how quickly I can get this off the plate. I don't have time to dig in and look at the data. Right? If I'm doing a peer-to-peer call on, say, a breast reconstruction case, there's no way that I'm going to actually inform myself about that. They just want me to deny it and move on. Yeah. And if I approve it, then someone leans on me. So yeah, I mean, I just think across the board that we have, like in chemistry where you have the equilibrium.
Yep.
Le Chatelier. Right? The Chatelier principle, where it's like the balance.
That's it's like taking me back to a place where I don't want to go.
I know. But I feel like we have this equilibrium and we're supposed to have a good position where we have, it's America. We have the business of medicine and we have healthcare, like the providers. And we want the patients to be somewhere on this balance where they're getting great care and also, the industry is healthy and the workforce is healthy and they're well paid and all of that. But we're so far away from giving good care and so heavily towards making money for insurance companies that we've lost it. Like, we have to reset in a different place, and that is going to be so painful for the industry.
Yeah, very painful. And they're smart in the sense of they're doing it in a way where most people don't see it. They'll create these roadblocks that seem really reasonable. Oh, we're preventing fraud, abuse of the system. And that's reasonable. We should do that. That's good. Let's not have fraud and abuse of the system. We've seen issues with huge cases of people abusing Medicare, Medicaid, millions of dollars, fraudulent screening programs that end up getting people procedures they don't need. But when they're creating these roadblocks, they're creating them to decrease spending, not to eliminate abuse. Because if you see who's getting rejected, for every one abuse case, I mean, there's got to be hundreds, if not thousands of cases that are rejected simply as a cost-saving measure. And I remember this from a TV show I used to watch on Showtime, House of Lies, where they were marketers. And they said, oh, hey, we'll get this promotion that will give people a rebate off of your product. And people will be so happy. But by the way, we know that most people won't go through the hoops required to do it. And then we'll deny the first set of them. And then the second set, only 1% will end up converting. So you're going to save a whole ton of money.
Oh my gosh, there's so much to say. There's right. It's the fact that only 1% of denials are appealed.
Yep.
So say you want to decrease fraud and abuse. Well, they're not just decreasing fraud and abuse. They're denying everything.
Yep.
The good stuff and
even
the
when
bad
the things
stuff
are appealed, over 50% are denied.
Again, so that's baked in to the business plan.
Yeah.
Right?
I've seen some stats from the Kaiser Foundation where like 19% of in-network insurers are denying cases, claims, et cetera. And then out of network, it gets up to double, even more than double, 38%. Think about the number of that. That's over 3 out of 10 claims are being denied. And while certain insurers say, well, it's better for us, ours are lower, I don't see that happening as a person who deals with it holistically on a large scale. I don't know if you do.
Just back it up and think about this. Like, we have people paying their hard-earned money for premiums because they expect that their risk is being reduced in some way. They're being taken care of in some way. And 20% of the time, they're being denied. Like, and what is the reason for denial? It's usually administrative or other.
Yeah.
It's not medical necessity. It's administrative or other. It's a technicality.
Yeah. And they thrive on that technicality.
Right. And I think it also, when you think about businesses that are this large, if they can dial up and down the expenditure, right? If they can deny enough where they know what the inputs and outputs are, right? That's helpful to them. It doesn't, it's more predictable as a company. It's also like, the accounting in these companies, you just have to wonder, like, they're just moving money around with all the different vertically integrated components. And in an insurance company, you have to have reserves too. So you take out of the reserves. And it's very complicated. It's not resulted in better care for Americans in the last 15 years. And we were sold that, right? There was a big study in 2008 that looked at, it was called like the triple aim in healthcare. And it was this revolutionary idea that, okay, now to have good healthcare, to have a good health industry, we're going to have to address, these three components. And they were like, let's see, cost per capita, the patient experience, and patient experience of care.
We'll fill it in.
Okay, sorry. So basically, it led to us doing vertical integration, right? It was like, this is the reason why we need to do this.
Yep.
Okay, so come 2022, and they're like, oh, darn, that actually didn't work at all. And now they've added in, we actually need to look at health equity, and we need to look at the workforce health, because we didn't think about that before. And we've set ourselves on a course that we're crashing. And then in 2022, Congress, asked for the RAND Corporation to look really hard at that. And they did this study that's so dry and so boring to read, but so eye-opening, because it's like, oh, let's look and see. Did insurance company consolidation help health outcomes? Looks like it didn't. Okay, let's look at, physician ownership by insurance companies. Did that help lower costs? Looks like it didn't. And they just go dispassionately through all these things, and it actually hasn't helped. So can we just admit it, that this whole creating monopolies of insurance companies has not helped us, and we need reform, and I think we need competition and transparency.
Yeah, all important factors. And I want to get back to your story. So you wanted to open up this practice that was doing things the right way, working with all insurers, perhaps pro bono at times. What was the journey like starting it? Troubles, issues, hurdles that you faced along the... Yeah,
I think, just the funding for it, that was hard. It's hard to start a practice, a solo practice. But I think when you take excellent care of patients, like the money was coming in, and I do a lot of volume because I take care of about 40% of the women in Central Texas with breast cancer.
Wow.
I do 20 cases a week. See, in a normal week, just me in clinic, I'll see 60 patients, and that's on 2 days. I do about 500 cases a year. So like just in volume, it did a couple things. It made me excellent. So there are great things about doing a lot of work. It made me take deep flap surgery from a surgery that took me 12 hours to taking me 4. Right? So like, I love that. And I'm all about efficiency and safety for patients.
And that improves safety because less time under anesthesia is helpful.
1,000%. Yeah. And I would never have been able to do that if I had been cherry picking only the cases that paid me a lot. So by taking care of so many people, I was able to like get better at this. So it seemed okay. It was okay for the first 5 years. And then reimbursements just started to go down and down and down. And then there was a big reimbursement change where
they made the code the same.
Yeah, they made the code the same. And that's when I first stepped into kind of advocacy and wound up in DC, just saying this is ridiculous. That's also when I first felt like, are you guys kidding me? I'm a doctor. What did
it shift to and from? And how did that impact percentage-wise your practice?
Okay, so the reimbursement cut was like over 50%. And the danger was that it would be cut to 10%. So by 90%.
Wow.
Yeah. And we know that.
And what was the initial coding for that then looped in your new code as well, or your previously new code?
So there was a CPT code 19364, and that code says breast reconstruction, and it includes any free flap, and that could be a surgery that takes all of a woman's muscle, or one that's super elegant and leaves her able to use her muscle, right? It just didn't recognize the difference between those things. And then the other code was an S code, S2068, and that was the code for the very elegant surgery. So when the societies decided to combine those codes together, and they actually put under the descriptor for 19364, they included like all of the elegant things and the garbage things, and the reimbursement stayed at the garbage rate.
Right.
Right. And I'm like, why are you doing this?
What was the major organization's reasoning for making the change?
You would have to ask.
Did they put out any statements about it, or?
I would say that was a very difficult couple of years. And there were some meetings that were very difficult. And I think that today that the American Society of Plastic Surgeons has evolved from the place where they were when they agreed to that coding change with the AMA. But I still have a lot of strong feelings about the fact that it ever happened. And they never allowed the code to be, like they still haven't recommended that the code be rewritten. They've just allowed for the existence of an option. That world is very dark. The world of the CPT code and the AMA is very dark. And I mean, by the way, the coding book is, it's published by United. It's Optum and the AMA. And the AMA makes what, $200 or $300 million a year on that? There's a vested interest in continuing that status quo there. So, I mean, we could have a conversation about RVUs and how doctors are not, I mean, that it's broken, but people are heavily invested in the status quo.
From a lobbying perspective.
Lobbying, but also just the existence of, I mean, we're locked into a system currently with RVUs that doesn't value physician work. Like all it values is, for me as a surgeon, like the time in the operating room, like the malpractice and the overhead. It doesn't reward me for doing surgeries that have better patient outcomes. Like the patient is even factored in. It's that system, and for folks who don't do procedures.
Yeah, for us in primary care, it's strictly numbers. It's a quota game.
It's
basically
ridiculous. Yeah. I mean, for my dad who's an allergist, it's like really, you guys, you're thinking about really complicated things. You're spending a lot of time meeting with people who have a lot of complicated intersecting systems at once. This is why concierge medicine happened.
Of course.
Right? And that makes complete sense to me, because we have, you get what you value. We set a system in place that doesn't value that physician work. And so everybody's played the game. All of us, right? We're trying not to. And I mean, physicians everywhere are fighting it. And we're trying to still provide care, but you can't not pay physicians and expect that patients are going to get great care. Like it just doesn't work that way.
Well, once the incentives change, you're just pushing people away from performing good work.
Or being doctors at all.
Yeah,
and now we're going to have a
true.
shortage.
Yeah.
I mean, let's just play it out, right? We will learn a lesson. Will we learn from the lesson? I don't know. But I think we're all in the middle of learning a lesson about healthcare in the U.S. It's ugly.
Yeah. So you were saying that it's not just the lobbying efforts, the RVUs. You were saying that there's more involved on the back end from these CPT codes and the AMA's role in this.
Yeah. I mean, I just think that, I'm not a conspiracy theorist, but having spent a year and a half of my life advocating for a coding change, I spent a lot of time in DC and heard a lot of stories and saw, I wanted the right thing for patients. It was clear that we needed to reimburse appropriately for surgeries that helped patients. And we're talking about women with breast cancer. People on both sides of the aisle agreed. And it always came down to money and the codes. Always. The government was like, we won't price fix, we won't price set. I'm like, what are you talking about? Like you guys do that all the time. You put a number on it. Say what's too little to pay and what's too much to pay. Like, don't overpay, but don't underpay.
Right.
And then, the CPT system, that editorial panel and the way it works is just so broken. I mean, sending out a survey to 40 surgeons in the United States asking, do you perform deep flaps, just like randomly to plastic surgeons, and how much time does it take you? Like, this is not science. This is not the way that you come up with a system that rewards or that guides reimbursement.
So the differences between the codes as how they used to exist, if you could lay that out in a simple way for me. This code represented this type of procedure. This code represented a higher level of procedure. Why was that considered higher level? What benefit did it give to patient? And what has now been taken away by grouping the two codes?
Okay. So simply put, S2068 for deep flap, that describes a code, a surgery that is far better for patients, doesn't leave them like disabled basically by removing their entire rectus muscle, and is better in the healthcare system, right? So we have patients who are using less opiates, less pain issues with surgery. They're not staying in the ICU for multiple days. Their length of stay is not 5 days. It's maybe 1 or 2 or 3. And they're able to thrive, right? They leave this experience of having had breast cancer and reconstruction, and they're able to go and live their life and run a marathon and do what they want to do with their bodies, right? They're not just disabled from the reconstruction. So that surgery, I think the national average reimbursement, I would have to look back at this, I don't want to missay it. I think it was around $20,000 for a deep, around that. And it might have been like 15 to 20. The reimbursement rate for 19364, $2,700. Okay. So that reimbursement is, honestly, I'd say if you're taking a woman's muscle and you're doing sort of this barbaric surgery, like I understand not paying a lot for that. I get it.
Now, forgive me for my ignorance on this. Why are people even performing the worse surgery? It sounds in every aspect worse.
It's easier. The difference is that surgery is easier on the surgeon and harder on the patient. It's not elegant at all. It's not, there's basically the hardest part of a deep flap surgery is me saving the muscle.
Right.
It's really hard and delicate. And I'm getting right up against these blood vessels and I'm protecting them so that I can save the muscle. In the other surgery, they just cut the muscle out and they never, and the vessel's inside it. So yeah.
Is the field in general moving away from that older procedure?
That's hard to say. Yeah, that's hard to say.
Is that a push that's being made?
We've made that push. And I think in our efforts with coding for that year and a half, we made that case very strongly with the American Society of Plastic Surgeons. And now I think it would be much more common for people to acknowledge the difference between the two. But our specialty has a long way to go.
It's incredible that in a day and age where we have just a superior treatment available, and yet we're saying, well, the other one's cheaper, so we're just going to do that one, when it has worse outcomes, and it seems like every sense of the idea of giving someone medical care.
Exactly, and that's why I was like, this can't be. If I could just make you understand, then we would change it. And so the win that we got at the end of that year and a half was that they kept the existence of the S code. So CMS agreed. The CMS
so it's like a modifier?
No. So the S2068 exists now. So CMS said, it's a very long and complicated story, but the government got it. And they said, the only thing we can do here is
mandate the existence of the code.
The S code. That's the only one we have control over. The CPT codes, that's up to your society and the American Medical Association. And we do whatever they tell us to do. That's just how it's always worked. So those two organizations would have to agree that that all of these surgeries weren't the same. So it's very, very telling that the AMA and the American Society of Plastic Surgeons wouldn't do that. And so still today in 2025, 19364 describes all of those surgeries. They didn't do what they could. The government did what they could. CMS said, we'll keep this code. Because I made the case to them, we made the case. We just need this option. The AMA and the ASPS aren't moving. We don't know why. It doesn't make sense. But please.
So when you write them or have meetings with them, what happens?
For the first year and a half, when I first did this, like the first phone call I made to the ASPS, they didn't even know what was going on. Like I sent an email to one of the presidents and he was like, I'm not aware of this issue. I mean, this is a cosmetic surgery society. Sure. They didn't know what they were doing. And then I had a lot of meetings and I hired lobbyists myself. And I got surgeons from around the country to call the ASPS and other societies to weigh in and make the case for patients. And we got patients involved. And they started to evolve under pressure, right? But that was not comfortable for me at all. I mean, there may have been a video that circulated of me that was circulated by the ASPS that was labeled disparagement. And it was me talking about this issue on social media where I said that they should do better. And
they circulated it in what way?
Via email.
Saying what?
Saying that I was disparaging the American Society of Plastic Surgeons.
Because they were offended. Mm-hmm. Okay.
Yeah, they didn't agree. So I'm just saying, like, if today they would say we support deep flaps and we support microsurgery that doesn't hurt a woman's muscle, I will tell you that in 2022 through 2023, they leaned very hard on me to be quiet. Mm-hmm. I mean, to the point where a president of the society showed up at my home.
That's scary.
Yeah. So, yep.
Like threatening?
No, in a very nice way.
And how did that go?
That went well. Yeah. I know bullying when I feel it. Mm-hmm. And so I stood in my kitchen and my husband was there and one of my dear friends who is also an Olympic athlete, and I just wanted witnesses. Mm-hmm. And she watched. It was me standing my ground for patients. And I made the case. And I just said, I'm not stopping. Like, here I am in my house. Like, I literally was in the kitchen on purpose with the roof leaking into a bucket. And this man who walked in the door with a bottle of champagne. And I'm like, you don't know your audience. Like, I'm all in. I've emptied my bank accounts. And you're bringing me a bottle of champagne telling me to be quiet? Like, this is not resonating.
And the hope was that you'd stay quiet and they would continue doing these codes?
Yeah, there were meetings where they said, we have looked into this and it's not in the interest of our members. This is not in the best interest of our members. And so what they mean is cosmetic surgery, right? They looked at the number of microsurgeons, the number of folks doing breast reconstruction, and we're such a minority in the whole society, right? There's 8,000 members and there's just a couple hundred of us. But my point to them was, but there are patients. If you are going to be my society, then you have to care about this, right? And so there was a Zoom call where a lot of folks chimed in and weighed in, and they laid out their case for why they didn't want to change this code. And it included things like they didn't want to, quote, open up the codes, which means they don't want anyone else. They don't want any other codes to be looked at. So they were protecting all the other codes in plastic surgery.
Like they didn't want to put a precedent in that these codes are
right. They said
open to modification.
Yeah, they said, whenever they look, if they open up this box of worms, they're going to decrease reimbursement for everybody, not just for you guys. Right? And I was like,
But why would they decrease reimbursement?
Well, their case was that the government does that when they open that historically. But I mean, I think this sounds just like a threat. This just sounds like gaslighting, right?
Yeah, it sounds like the opposite of what would happen.
Correct. And that's the opposite of what actually did happen because I didn't shut up. And I just went another direction. I went straight to CMS and the lobbyists did their job and lots of members of Congress weighed in and were supportive. But no, the society, they had their reasons. And the first time I saw them really come around was when we had our meeting with CMS. And they sat there. I think they saw the fact that I got a meeting with CMS, right? And we had literally thousands of people writing letters and we formed a coalition of nonprofits. They had to show up with a different statement. Mm-hmm.
And there's no sub-organization that works specifically with breast reconstruction?
No, there's the reconstructive, like the Microsurgery Society. It's really small. And around breast reconstruction, they kind of seem to do what the ASPS told them. Specifically with regard to that surgery, the person who was the president of the society or the former president of the Reconstructive Society was still performing that surgery, the one that removed muscle.
Right.
And like advertising it. I mean, that's how much they cared about this issue. It was like, okay, if you're not performing the better surgery.
Don't speak for them because we won't say who that individual is. But if I ask them, why are you still performing the surgery where there's a better one available? What would be their response?
That's the one I know to do.
Mm-hmm. Even though it's significantly more harmful for your patient.
I think so. It's so much harder. It's very hard to do perforator flap surgery. I mean, the focus it takes. But I would say it's better to do nothing than to do a surgery that removes a patient's rectus muscle. It's better to just send them to someone who knows how to do a better surgery.
And I'm surprised that organizations that perhaps are not focused on the reconstructive side of things, Komen, some other breast cancer organizations, they weren't participating in advocacy alongside you?
They were.
Oh, they were.
They got on the coalition. That's how this changed.
Got it.
Yeah, I was talking with the American Cancer Society, Komen, we had a huge coalition of nonprofits. We had patient advocacy. That's social media. That's why this changed.
Got it.
Because I got nowhere with the traditional paths. Nowhere with my society. Instead, I paid for lobbyists and I went to DC.
And how did you said social media, how did you use social media to make this happen?
We just had Instagram Lives and we talked about the issue and introduced it to patients and just said, write your Congress people. And then we made that easy for them. I went to the Hill with patients. It was a huge movement. There were probably, I don't remember the exact number of patients that signed on the letter, but in the breast cancer community, people know that happened nationally. That they were a huge force for change. And that taught me about, the power of the patient and the power of social media.
I have to ask, how does one hire a lobbyist?
Well, I just called them up and they were
1-800 lobbyist? Where do you find a lobbyist?
No. So, I asked some friends, and a friend who was familiar with the issue said, you should call this person. And I called, and that lobbyist, they were great. And they saw the issue for what it was. And like everybody, they had an experience with breast cancer in their family. And they went to the mat for us.
So they basically get you connections with people who are in charge of making these decisions, the committees, Congress people, senators. Is that how it works generally?
Yeah, well, they got connections with the offices and asked for meetings. And then I would show up to DC and go have 20-minute meetings.
And you're not getting compensated for this. I want people to
I'm paying for the privilege.
Yeah.
Right? I'm paying a lot of money a month for this. It was actually $10,000 a month.
Wow.
Yeah.
And you had this success. You got CMS to hear you out, to make the change. What did that victory feel like for you?
That felt like I breathed a huge sigh of relief because I was afraid that my career and the practice of breast reconstruction for all of these patients was going to come to an end. I really felt like that's where we were going if we couldn't honor patients in this way. If we couldn't take care of women. Just this very simple argument, if that wasn't understood at the national level, I thought we were headed for disaster. So I just felt relief. But yeah, I'm not someone who celebrates well. I always I'm on to the next. But since that time, I know that that's changed women's lives around the country, and they've told me that, and I've heard from patients, and I'm proud of it. I wouldn't change that. I wouldn't change it for the world. It definitely got me ready for United because literally, like, I'm not scared. Yeah. That was like a warm up. Yeah. And when United reached out and I felt those feelings in the moment, yeah, I had all the feelings. But I also had an experience to draw on where I was like, I've been up against somebody before.
I've overcome before.
Yeah. And I know who I am. And I'll take it back. I was scared. I was scared. But I know how to do this.
Well, if you weren't scared, something was wrong.
Right? But yeah, and it's also like, so I'm glad, and like so many things in life, I'm really glad for the experience that I had advocating and dealing with societies and people who bullied me, right? I'm glad for that experience. It made me stronger, and it made me ready.
This is missing in society quite often. Purpose. But you're like exponentially elevating that purpose. You're showing up for your patients as best as you can to accept all insurers. You're performing procedures pro bono. You're being the best doctor that you can by minimizing time that the surgery needs, how much time the patient's under anesthesia. And then you're like, well, I'm not doing enough. And you're like, I'm going to put my own money in to lobby to get this foundational change to happen. How do you drive yourself to do all this? What's your motivating principle there?
When you say it, it sounds much more impressive than it feels on the inside, but I think it's just...
Well, I think you should feel it. It's bigger than I'm even saying it.
It's, I feel my sense of purpose deeply. And this is like, this kind of conversation is like this is where my superpowers are, right? Because there is something deep inside me that just says, do the right thing. And I like the hard thing, right? I like finding out who I am. I like the experience of getting uncomfortable and going, like, recognizing that that's an opportunity. And I also know that that's not something that everybody's willing to do. And so that makes it feel like it's a place to make change. Right? Because if I'm not willing to do it, who else will be? It's hard to explain. But
how do you develop that moral compass?
I think that goes back a long way, probably. I think that I listen to patients and I'm listening to what they need. And they don't just need a good surgery. They need for me to care about their whole path, right? And I do. And so for me to care about patients with breast cancer, I have to care about doing a surgery that's healthier for them. I have to care about insurance too. I have to care about their financial health. I have to care about how, the hormone blockers make them feel. Like, sure, I'm a plastic surgeon, but I'm also just a human trying to lean in as best I can where I've got influence. And that feels good to me. So like I learned somewhere along the way how to, like, in a very meta way, kind of cheer for myself. I didn't do that when I was a kid. I was always motivated to work really hard, but I wasn't, like, internally proud of myself. I can now look at myself and go, I'm glad you're doing that. I know it's hard. And that sounds really weird, but it's motivating. Like, even in the hard moment, I know who I want to be. And I'm proud of myself for doing the hard things.
If you had to give advice to someone that was listening right now that wants to develop that, is there any tips you can give them?
Gosh, yeah. Get to know yourself. Really get to know what drives you. And don't judge it. Like, just figure it out. When do you feel good? When do you feel like you're in your zone? For me, like, there's specific things that I do every day that get me ready. And figure those things out. I think accepting discomfort, being willing to be in those moments and looking for opportunity. There's so much of this is about perspective, right? You don't have to go out and seek some experience to do this. Like, just live your life. And in those moments where you feel like there's a challenge, just say to yourself in that moment, what's the opportunity here? Why does the universe keep presenting me with this challenge? What have I not learned yet? How can I get better? How can I make other people better? How do I change the temperature of this room? Right? What's the legacy I want to leave? I mean, I literally think about these things all the time, and I'm open with my friends about it and my family. I think maybe even just...
How do they react to it?
They love and respect me now. But I mean, to the point where...
I mean, I hope they loved and respected you before.
No, they do. But I just mean, I think it's what I value, right? Like when I, spent my savings on lobbying and all of that, or even going up against United, having conversations where I would say, I'm not going to leave you an inheritance, but I'm going to leave you a legacy. And that sounds like a line, but I mean it. Like, I don't have kids. I don't want to leave here with a bunch of money. I want breast reconstruction to be different because I was here. Now I want healthcare to be different because I was here. I want the way that Americans interact with insurance companies to be different because I was here. So, yeah, there were those times when, the nieces or nephews were like, you're never around, And yeah, that's a sacrifice. And, I do need balance just like everybody. But I know that my family is proud of me. Yeah. And that means a lot. I mean, I'm just a kid from Georgia, like my family was very humble, and I've always known what it's, my family means a lot, and where I came from means a lot. So, yeah. It's
hard because you look at yourself as a kid from Georgia, but you're much more than that. And you're much more than that to not just your patients, but to people you've never met that you're having an impact on. Have you heard from individuals who've had their lives changed by the procedure that you advocated for?
I have. And that's so heady.
Yeah.
Right? And I would love some advice on how to process that from someone who has this impact around the globe, but I'm just so thankful for that. And it's reinforcement. It helps me know I'm in the right place, and I receive that, and every individual matters. And that just, it's like, why be on social media? Why even do this? Well, you can affect more people. There are people who need to know. I think it affects me. I hear from people all the time, and it's almost like unbelievable. All I can do is I kind of put that to the side and just keep moving forward, trying to do the next right thing.
Right.
Right? Because I feel intensely that I'm in a zone. I'm in my purpose. I'm on the right path. And it's like all those times when I told people, where it's uncomfortable, there's an opportunity. I'm like, oh my God, there must be so much opportunity.
Yeah.
This is so uncomfortable.
Right.
It's so uncomfortable. But yeah.
Do you ever feel like you're in a video game and the stamina bar keeps dropping, but then every time you get one of those letters or statements from a patient, it kind of refills it like a little booster?
Even just last night, on the plane, lately, sometimes I get, again, me saying I'm not scared is not accurate. I am scared. I have moments that are more scary than others, and I've had some of those recently. And I worry about, the pressures being applied to me. And I saw some comments that were posted on a video that I did, I don't know, a month ago.
Okay.
And it was like, keep doing what you're doing. It might be scary, but you're changing the world for the better. Those kinds of things. Or, just last night, reading those things made me less nervous. that's real. I'm actually really thankful for the community that has rallied on social media. I'm not just giving, I'm definitely receiving. Yeah.
That's powerful. For me, I've gotten hardened in my years of being on social media, in that I've grown accustomed to thinking that a lot of the negativity or positivity could be fake. Bots, people who are unwell, people from other countries trying to distort communication in the States. There's so many weird scenarios that I've seen play out over a decade being on social media, that I think unless you know, like you get an email from someone, you can pretty quickly realize where this is a person who's reasonable, who actually had something happen and is being grateful.
Yeah.
Versus comments on social media, I think it's much harder to gauge its authenticity. So for me, I've actually, to protect myself, have disconnected even from the positive comments on social media, for fear that I'm being driven by the comments, whether they're positive or negative.
That's so good.
Well, it's good, but it's also can be problematic, because as you were talking about that equilibrium in our MCAT studying, that equilibrium exists in that mass communication space as well, where if you disconnect too much from both positive and negative, you end up with PTSD. PTSD, patients who suffer with PTSD, a lot of times will try and pull back their emotions so hard to not have one of those outbursts or negativity spells, that they actually don't get enjoyment either. So you have to be very careful of, don't let it impact you, but let it impact you sometimes, and try and strive to seek some sort of balance there. And it's very messy because we're humans after all.
I'm just taking this all in. I'm trying to like press record in my brain, because I mean, I have so much to learn about this, and I feel like I know when things feel healthy and when they don't. And there are times when I just have to put my phone down.
Yeah.
I can't.
Are you good at that? Because I'm bad at that.
I'm bad at it. Okay. I'm bad at it. And I'm always like, is there something that I need to be like addressing? Or I'm going to think on that. I think that I tend to be someone who's detached. Like that's been my coping mechanism my whole life. You know, I've been able to just like cut the emotion off and do the work.
Right.
And so,
which is what healthcare training basically inspired us to do.
So much wrong. There's so much pathology.
Yeah.
So, you know, I mean, I've been on social media a little bit of time, but I haven't had a lot of attention until really this year. So in that period of time, I've actually felt like an emotional engagement, like from me, or like I felt safer to like be emotionally involved in the work that I'm doing. I don't know if that makes sense.
It does.
But yeah,
because you struck a nerve.
Right. Maybe it just resonated so deeply where I was like, I needed that encouragement. I try to have enough purpose for it not to matter how it lands. Right. Even I don't want to be scared of the reaction.
Right.
I just want to be so sure about the message and the truth of it that I'm good. And that's the power, right? And that's the thing, like with my patients who have cancer, and I'm like, oh, but you get to control the response. Like as long as I'm good there, I'm good. But there are moments when, like last night, when a comment, maybe it's from a bot, but maybe the universe sent me a bot, you know, to make me feel good, and I'll take it because it felt better. You know?
Well, that my fear is, will I feel badly when I see the opposite?
Oh, no, don't. If you see the opposite.
Well, no, I'm just saying in the hypothetical.
I know, but I'm just saying from me to you. Like, I just want, you know, if this is like my gift to you, it's like, just hear my voice going like, no, just put that one to the side, and I'll delete them. Like, I'll block somebody.
Okay.
I'll block somebody. If they come to my space and insult somebody there, I mean, no, thank you. No room for that.
We should give listeners some context. 2025 has been a unique year for you, to say the least. Tell us what happened, how this year got started in such a social media frenzy that it was.
I made a post, like other posts I've made in the past, but it resonated pretty broadly. So I was operating and got a call from an insurance company, United Healthcare. And they were asking for just like basic information about my patient who was actually having surgery. And it was just so absurd that they needed her diagnosis and wanted a justification for her overnight stay. Like in the middle of operating. They reached me in the operating room. It just, the absurdity of it made me post. And I just said, this is what happened today. And
you obviously said it not expecting
oh no,
some sort of heavy response.
If I had known, well, I don't know.
Would you have done it differently, maybe?
That is a good question. I think legally I wouldn't have said the name United because then I wouldn't have had the pain.
Right.
But also my life's trajectory has changed because I said United. And so I'm okay with that.
Maybe TBD on
TBD.
whether or not you change it.
I learned a lot from that.
Well, let's keep going with the story because
so-
this is interesting for folks.
Okay, so I posted and that post went viral.
And the post, you told the story.
That was it. I just said basically like,
Here's my day.
Here's insurance. I don't have words for this.
Yep.
How did they get me in the OR? This is ridiculous. And that post went viral. And then,
And describe to folks, because viral could take so many forms. Like I have YouTube videos that get 1 million views regularly. To some people, 1 million views is viral, but your story went viral.
well, I mean, I haven't tallied up the views, but someone has told me it was like 14 million across. So
I think it's much higher than that.
okay, I don't know. I haven't looked. I seriously, you wouldn't.
Yeah.
I don't even know how to look.
Well, it's hard because you have to compile all the social media platforms. And when someone makes a post on X and doesn't.
Oh yeah, there were so many.
Yeah.
Yeah. So it got around and
Tens of millions.
okay. I'm going to trust you on that. It was a lot. It was to the point where people were calling me from around the world, like asking for my story and what happened.
News agencies calling you, I presume.
Totally. Yeah.
And they're calling you direct, or how were they reaching you?
Yeah. Cause I mean, I'm just a person. They were emailing my practice or sending me a message, or calling the phone.
How did you realize, like, what was the moment that you realized it was getting so much attention?
The day after I posted it, I walked into the hospital and an orthopedic surgeon walked up behind me and patted me on the back and was like, thank you for saying that. And I was like, what?
So you weren't aware yet?
No.
Wow. Okay.
No. Because I was going in to do more deep flaps.
Yeah.
Like it was like a
regular day.
Totally.
Yeah. And did you then grab your phone?
Yeah. Well, I mean, I had noticed that like my phone was kind of beeping a lot and then I had to turn off notifications on it. But at that point I wasn't like checking. So that was just strange. But also I was like, this is actually really interesting. And I'm glad that this is getting some attention because it needs it. Because we've gotten out of control.
And the initial attention, was it people asking questions, thanking you, angry with you, all the above?
Most of them were, think back. Most were positive. There were some negative, for sure. There was some negative from plastic surgeons. There were some negative from surgeons saying like, why did you take the phone call? And I had to explain. So like, yeah, I'm in the operating room. Why would I take a phone call? That sounds like really irresponsible. And I went through the process of, oh gosh, now I have to explain to social media why I took the phone call. Okay,
Right.
So I have a partner in the room. There was a doctor in the room,
Right.
Still operating. Also, I was afraid they were going to charge her for the surgery. So I'm thinking about her, financial health and all of that. I mean,
And usually they're not reaching out to you mid-operation.
they literally sent a message into the operating room and there was a Post-it note, United, the patient's name, call them back. Like they're asking to talk to you right now. It seems urgent. Like the nurse manager, it went through multiple levels to get to me in the operating room. And then I had a 2-minute phone conversation with them, but
And what was it like in general referencing? The patients, whether or not they should be getting the surgery?
literally it was just the most mundane details. What's her diagnosis? Why does she need to stay overnight?
So it was about the stay,
Yeah,
which should be figured out after the
totally.
fact.
There's no reason today why this needs to happen. And why am I having to think about this? But that's what doctors around the country are experiencing. Why?
And I'm assuming, correct me if I'm wrong, that you don't think that this is happening where insurers are constantly calling people in the operating room, but you're pointing to the bigger picture here where these insurance companies in their denials are being so aggressive that it's even reaching you in the operating room.
Correct. And the feeling that I had for, more than a year before that with insurance, this whole coding thing led up to it, right? Like the feeling that I had was if an insurance company tells me to jump, I say how high. That's what it feels like for me to do breast reconstruction because they could just not pay or charge the patient. I mean, the stories I heard and dealt with prior to this call led me to this feeling of if I don't address this, something bad is going to happen to this patient. So yeah, no, I don't think that people are being called out of the operating room routinely, although I've heard from surgeons who've said, I've gotten a call on the way to the OR, very similar things.
Sure.
But it's just in general that we have to deal with insurance companies in the middle of the day, certainly interrupting care. I mean, I've heard that.
I mean, I do that all the time.
Right, peer-to-peer, we have to
Prior
talk to you by two.
authorizations,
Yeah,
I mean-
it's all day.
Yeah. I've had prior authorizations for the most basic antibiotics because I prescribed capsules, not tablets on the electronic health record.
I mean, why?
Well, because they didn't do a great job negotiating capsules and they did
know.
tablets, but
But America, did you know
argument,
this?
yeah.
It's just ridiculous. Like, let's just stop it. Let's stop it. I mean, because think about that delay in treatment. So you have a delay in giving the antibiotic,
Sure.
right? That has a medical outcome. And at some point,
and how do you quantify that?
yeah, and at some point that feels like you're making a medical decision. Now I know that's a broad leap, but like when an insurance company tells me you can't operate for another 2 months just because on a patient with cancer, that feels like they're making a medical decision for that patient. They're overruling me when I say I want to do it's time for surgery, or when they deny whatever. Like
When they make those denials, what are they basing the denial off?
I mean, which one?
Well, like in your mind, the hypothetical you're going with, you're saying the patient needs this now,
I just
and they
had
say
that case.
2 months.
Yeah,
What's their logic behind
they said that they had literature to support that. So
to
that,
support that they should wait?
Yeah, so this was a woman who had a unilateral mastectomy. She was in her 30s. She had one breast removed for breast cancer. And that was like a year and a half ago. The night before that surgery, so we planned to remove both breasts. The night before that surgery, her insurance company denied the contralateral mastectomy. They said, we're not going to pay for removing the breast that doesn't have cancer. Okay. So the morning of surgery, patient was informed that their insurance company had said that by the breast surgeon. And they were like, this is so stressful. Let's wait. And when you're having reconstruction eventually, let's do the other mastectomy. So you're going to have another surgery in the future. Let's just do your other mastectomy later. So she was like, okay. So basically the patient agreed on the morning of surgery to only have one breast removed, not both.
And the reasoning by your calculation to remove both was what?
Well, the patient's so high risk, family history. She was 36, she had an advanced disease. She was counseled about her risk, and that was a choice that she made with her breast surgeon. So I'm the reconstructive surgeon.
Got it.
Then there's the breast surgeon who does the cancer part of the surgery, and they had made that decision with her.
So that's the part that got denied.
So first, that was denied.
Got it.
So then fast forward a year, and this woman who's had the breast on for a year because it wasn't removed at the first surgery, and has completed chemotherapy and radiation, and then waited 4 months because I, as a microsurgeon, know that 4 months after the end of radiation, I have a 99.7% success rate at doing a deep flap. So 4 months is good. And there's no literature that supports longer. And I have lots and lots of data because I track everything I do, like times and all of it. I have lots and lots of data to say that that's the right time for me to do that surgery for her. So I submitted to the insurance company and I said, I'd like to do her deep flap reconstruction. And also it's time to do the mastectomy on the other side. So we're going to do both sides. And the rigmarole that they sent us through was ridiculous. They said, no, 4 months doesn't sound right. Let's wait another 2 months. And I'm like, why? I'm the doctor. I'm the one. Well, we have some data that says that 6 months is recommended. I'm like, that data doesn't exist. There's no guideline that says that. Right? But I had to go through multiple calls, finally get on the phone with an oncologist. Finally, I got an oncologist and explained to the folks that I could do this at this time. And they also at that time were saying, we're not going to cover the other mastectomy still. So they revisited that again. And I had to explain, no, she has one chance for me to do deep flap surgery. And if I don't do both breasts now, I can't come back and do it later. And she has chosen to have her breast removed. And by the way, these are her risk factors. And this is why. It was just, that's just a couple of months ago. All of this extra time with an insurance company turning the screws and practicing medicine, I would say, but also delaying a mastectomy. Like, I've had patients before who, their mastectomy has been delayed and we found more cancer than we thought we were going to find. There's a health implication to delay. And companies that practice in healthcare and insurance really need to be aware of that. I'm sure they are. We just have to point it out.
Do you think the delay is truly in the patient's best interest from these companies, or is it usually a way to wait for the patient to fall off the plan, a way for someone else to take responsibility from a financial standpoint, like they're swapping and let's say they're 65 years of age now, or are they thinking about the patient?
I can't imagine how they're making that decision by thinking about the patient. I was the doctor. I had all of the data to support it. It just seemed financial. And it happens over and over and over again, where I feel like the delay is part of them controlling cost. It's a dial they can turn. And it's, if we deny this, if we delay this, then,
Profits will be X.
Yeah. And I do think that a lot of insurance companies got dinged for denying things after the fact. So I've felt a move towards slowing down ever getting to the OR. That's another way, rather than doing the surgery and then them saying, we're not going to pay.
Yeah.
We felt, we won't do this surgery yet, or we're going to make this process drag out for another 2 months. And I've certainly had the, aging into the Medicare population.
And all with the same notion as the marketing principles from that show of, there's going to be attrition.
Of course. But again, these are companies who have a fiduciary responsibility to maximize profits for their shareholders. And we're practicing medicine. And we have a responsibility to do the right thing for our patients. And we have to meet in the middle somewhere. It's ugly.
And there is a balance to be had there. Yeah. But the balance is just so off.
Well, yeah. And that's
if you had to say, let's say the perfect balance is at 50, and then other side is 100 all business or 0 is all patient, where do you think that balance is now?
I think we're 80% towards all money.
Business side, yeah.
Yeah, I do.
I think that's a fair number to be.
Yeah. And I know that we can improve it just by bringing awareness. I know that's, people just say that all the time, but if we don't know it, if we can't explain it, if we haven't made it understandable for the average American, then okay, they're just going to keep doing what they're doing.
Well, that's why people love to dunk on social media as being problematic, negative, and there are definite drawbacks to social media. But one of the huge undervalued impacts of social media is the success you had by adding that code or returning the code.
Yeah.
The conversation we're having here to potentially put pressure on insurance companies to make a swap, or the government to force insurance companies to make the swap, because odds are they're not going to self-regulate to turn a smaller profit. So I think this is a great avenue for it.
I think it's the avenue for it. This is, the most democratic thing around lately. All voices being heard. And it's there's good and bad, but let's get the information out there. And
well, that's the quote that you said earlier, that if people just knew, they'd make the change because it's just so logical. They're just not aware of it.
Yeah.
Well, social media will kind of evens that playing field and allows us to tell people.
I love that. And I think the business of insurance is so convoluted that the more I understood about it, the more I felt like, wait a minute, that can't be real. I want the public to know about, the 85-15 rule. And I want the public to know about vertical integration and what that means. so that we can all apply pressure for better. And even, I'm not saying I know the solution, but let's talk about it, right? There's a lot of other options out there, and there are insurance companies who are trying to do better.
Yeah.
Yeah.
Orthopedic surgeon claps you on the back, says, great job.
Oh yeah.
You're getting all this feedback. That's wonderful. Some negative that you feel you ought to correct. What happens then?
Then I think really the next big thing that happened was that United sent me a threatening letter. So there was quite a response on social media, and they basically sent a letter that was 6 pages of, saying that I had lied and that never happened, saying that I was allowing violent communication to exist on the internet with references to the murder of their CEO in some of the responses. It was just a whole litany of things we think you've done wrong here. It was just gaslighting gone wild, right?
How'd you feel when you get that?
I got in the middle of the night and I was scared, but also my heart was racing, and I'm like, what is going on? I read it through and through. And
did you agree with any of their criticisms?
No, I truly didn't. And I knew that what I said was true. And honestly, talking about the murder of their CEO, there were comments left that seemed to be supportive of Luigi Mangione, right? And that's something that I've seen pop up. And at that time, I was just doing my work, and I wasn't spending my whole day going through the comments, deleting things that sounded negative. I didn't even know how to filter out comments at that point.
And especially the volume of comments coming in during that time.
Since then, if I see something that's really blatant, I'll just delete it. I don't condone
They're
violence.
acting like you're a corporate entity with a giant social media team monitoring comments.
I'm just a lady.
Yeah.
I'm a surgeon. I'm still operating, and I'm doing my best. But also I do think that...
And that's not your responsibility either, to police speach.
There you go.
If you do it, cool, or good on you.
If I need to, yeah.
But that's not a mandate.
No. And also, I felt this sense of this need for the public to speak. I felt that after Mr. Thompson was murdered, and the response was so complex, right? I felt like people are getting something off their chest. And is it very tragic that someone lost their life? Absolutely. Is it very tragic that people are having to navigate the healthcare system that leaves them feeling like they've been harmed in such a deep way that they have to lash out here?
Yeah, you're not equating them. You're just pointing out 2 tragedies happened.
I'm just saying, and I actually think there's something healthy about that communication existing in the world, right? So when I meet a patient who has breast cancer, it's not my job to tell them how to respond to that. They have your feelings. Be angry, be sad. I'm not here to tell you what to feel. And I felt the same about people's responses in a way. I'm not telling you that you shouldn't feel that way. Actually, the more I listened, the more I saw really deep problems that were, not just in my world of breast reconstruction, that were so much broader. And I felt the need to lean into that. But that letter was, that was scary. And again, here I am saying I wasn't scared. Yeah.
Well, it's okay to be scared. That's normal.
Yeah. That morning I went out to my car and I texted my sister and told her, and she said, we're house girls. That's my maiden name. She's like, we're house girls. Just give them hell. And I contacted an attorney who was amazing. And then we went from there.
Now, in taking on United in this battle, because it's become a battle of sorts, had they reached out to you and said, we want to make sure this never happens again. We feel like some miscommunication happened, but we want to do better by our patients, and we want to include you in that revolution. How would you have felt if they've done that?
I would have loved it. I would have loved it. And I would have been like, oh my gosh, when and where? Let's go. I'm going to go to Minnesota. Right? Like I'm in that, let me tell you what I've learned.
Why do you think they chose not to go down that avenue?
I honestly don't think that they, for whatever reason, were really engaged with who I was or what I was doing or who my patients were. Like, I don't even think they realized that I'd been advocating for access to breast reconstruction through insurance. Like, I'm on your side. I've actually been going to the map so that patients don't have to go out of network and cash pay, right? I probably do 1% of the breast reconstruction for United. Like, when you back in the napkin calculations, like I do a lot of breast reconstruction for them nationally. So I just don't think that they knew that I was not a bad actor. And they thought I was someone that they could bully. And they probably, honestly, I think they thought, what's the quickest way to make this go away? Because it's been a rough couple months for us and we don't need this publicity. Mm-hmm. But, I had a different kind of reckoning in that moment. Yes, I care a lot about insurance and I care a lot about my patients and I care a lot about advocating for access to reconstruction. But there's some moments where, I just feel like I'm being asked who I am. And that was one of those moments where, am I someone who's going to just back down because I'm scared? Or, am I that girl from Georgia who just goes, okay, well, I know it's right. I know it's true. So come at me, Yeah,
and I also don't even understand what the ideal outcome is for them.
I really think it was for me to be quiet. I think they send these letters out. Maybe it's that they see what I see now, which is that.
And you made the letter public.
Well, that was great advice. And I think sometimes just letting someone's words, speak for themselves. Like if you're in a meeting and someone says something really nasty, just pausing and letting it echo in the room for a moment. That's kind of what this was. It was like, okay, let's just let everybody read it and see how United talks to a woman who's devoted her life to taking care of women with breast cancer through insurance. Let's just let that hang out there. And it felt wrong. And people felt that with me. Yeah.
It feels like, zooming out from this example, that crisis PR folks are not great at their jobs.
Who was advising them?
Because it almost would have been a good story.
Oh my gosh. And still, here's the thing. It still can be, guys.
Yeah. Like
it still can be.
You agree that there's something wrong. You're passionate about patient care. They describe themselves as passionate about patient care. Why not come together and do something meaningful? Even if it's not 100% of what you hope to achieve, there's got to be some middle ground of making progress in at least a positive direction. Like as bad as it's become, right?
Yeah.
So I don't know why that approach was taken. That's very interesting. I read, I'm a Reddit person. I like reading negative comments on Reddit as my hobby to make myself feel bad at night so I don't sleep. But I was reading a few comments of people pointing out that the insurer likely called you because of some rule that exists in Texas about inpatient versus outpatient stays and how outpatient observation is different than inpatient based on the number of nights. Was that the reason why this whole mix-up happened, or is it deeper than that?
I think it's deeper than that.
Okay.
Yeah. I mean, I don't buy that, but.
Yeah, this just happens so often. I remember this is probably this week or last week that I was seeing a patient who on ultrasound had a 1.5 centimeter mass in their liver that they said better examine through MRI, recommend further imaging. And I order the MRI, it gets denied because my interpretation of the interpretation by the radiographer wasn't in my note. But the note is connected to the report.
Yeah.
And I don't know why. And again, all of that is just another hiccup where they're like, oh, it's a hiccup that will get solved. It's like, but the more hiccups you have, it's like the same way when you're trying to create a good user interface. Like the electronic health records, we all agree is crap. Ugh. But for example, Apple has done a great job with cell phones, right? That's why people love Apple. So the more clicks it takes to get to something, the less you want to use it.
Totally.
So here, instead of more clicks, they just have more steps. And they call them hiccups or administrative blunders or what have you.
And don't you know that they know that that's slowing it down?
Of course.
Right.
But it's, again, I can't prove that.
Yeah.
That's my assumption. Or maybe they are saying, well, we're trying to do it for reasons X, Y, and Z, but there is just this added benefit that is being neglected. So to me, if I'm running an organization and this is me running my own, let's say, organization that's doing insurance, someone accuses me of that, and I am firm in that profits aren't the reason why I'm doing it. I will then say all the profits that are gotten from surgeries that didn't happen, procedures that didn't happen, will go to serve X causes. Because we want to make sure that it's clear that we're not doing this for the financials. We're taking all of our incentive away from it. But that's not happening.
Again, though, I mean, I love that you're framing it in this way, because I do feel the opportunity and the discomfort, and there's still time, right? I mean, United specifically has had a leadership change. Their CEO stepped down. There's, one of the board chairman came back. Like, I know they're looking hard at their company. I know they are.
Well, it's a shitty position for whoever's in charge, because you are not someone running a nonprofit. You're running an industry that is facing a reckoning. And are you going to be the person that does the right thing and cuts your business? Or are you going to be the person that drags it along until the next person works so you can get your bonuses and payouts, et cetera? Again, they're not a nonprofit company. So
I know.
How do we expect them to just have an internal reckoning to make a big change?
Well, if they're not going to do what's right for patients, they shouldn't be in the business of healthcare. I mean,
I agree.
It is the business of healthcare, but I mean, I would say it would be a good investment to make a pivotal change right now. It's kind of like, private equity versus like long-term investing. Like when you're thinking about private equity, it's like, I got to turn this around and get out of it in 5 or 7 years. You do different things. Why don't you just recognize that this is a long play, right? Do what's right for the next 20 years. And I'll help. I mean, I'll help. Lots of us will help. But we can't keep doing more of the same.
Yeah, it's hard to get doctors in your corner to cheer you on when the business is functioning as is.
Yeah. No, and I think we need competition, and competition brings out the best in everybody. And it's, we need something in the market other than what we have now. And
incentive change from government could also be a role here.
Totally. But I think that also with the ACA that, physicians can own hospitals, I think reintroducing that, I think that creating space for the direct care model, which is, like concierge care, but different. I think that making a space for that with employers would provide a lot of competition that would be very healthy.
Yeah, I have no idea where this is headed. But after you were in your car and you talked to your sister about taking on the challenge, what came next?
So we posted the letter that they had sent to me. And there was a week of me weighing that. Like, is this, my attorney told me this may be difficult for you. Are you sure you want to do this? And I decided, yes, we're going to do this. And then the response was really overwhelmingly positive and supportive towards me, and appalled at the insurance company treating a doctor and patients in that way. I just think it was like people get little looks at an insurance company from different scenarios. And I think they've just had a lot of glances from different perspectives lately. And this was another one that added up to something is amiss.
What about press?
Yeah, so people called. I'm not used to that, but there were a lot of folks from around the country and even other countries calling, asking for my perspective. I learned, quickly about how to speak with reporters and what background is and,
And how did all that go? Like, do they invite you on morning talk shows? Are they inviting you for quotes and subtext in a New York Times piece?
No. I mean, there hasn't been, I would say there were like The Guardian, there was like Bloomberg News, there were some online news things. There were, it wasn't as big as people reached out and then didn't publish things too. And I don't know how that all works.
Interesting.
And then there was like a separate thing where like a prominent investor weighed in, and that created a different vibe, a different tone to the inquiries I was getting.
Right.
So
where do you see the conversation existing today?
Today, I'd say that it's taken off from that point. And now what we're interested in is talking about the truth of healthcare in the US and exposing and shedding light on what's really happening for patients and providers, and creating a space where it's not just complaining, but, an opportunity for listening to multiple viewpoints and making change. Like, I feel like I personally have found something that I'm supposed to be doing, and I'm glad to have that. It's a privilege for anyone to care what you think about something. And I take that responsibility really seriously. And if I'm going to speak about it, I need to do my homework and be adding. So I think the conversation is I don't know where it's going to end up yet.
Well, I guess it leaves open a part 2.
Yes, it does.
For our conversation to see where it went and how change actually happened. At least I hope happened.
Yeah, that's awesome.
What's the takeaway from the journey thus far? If you had to tell yourself 20 years ago, hey, be prepared for X.
For me, the takeaway is know yourself and get in that zone and know what it feels like to be in your purpose. Yeah. The takeaway for me is like, you're okay. Just keep going.
It's funny you say know yourself. I have one tattoo, and it's know thyself.
Oh my God. But that's like, I only get this one, so far as I know, body and life. And like, I'm going for the resonance. Like, I want that frequency where it feels like I'm at my best and I'm having the most impact. Like, both things are true. And then I want to exist in that space.
Fair.
Yeah.
Practical tips for providers and patients dealing with insurance blunders. Anything you've learned along the way?
Get on social media.
Okay.
Yeah. Seriously.
Loudspeaker.
Yeah. Get on social media. The truth is an absolute defense to libel. Don't elaborate. Don't embellish. Just speak the truth. Let people know. And I think that has real power. And don't accept a denial at face value. Appeal.
Yeah.
Yeah.
With, I believe the last number I saw was $220 billion in medical debt in the United States, which is these numbers are over 6% owe over $1,000 in medical debt. I mean, the numbers are staggering.
It's staggering. And those numbers do not accept. Don't just write the check for the bill that comes in the mail.
Yeah, fight it.
Negotiate it down. There are companies to help with that. I think there's even apps out there that help with that. Like, look for
prescription drug companies.
Totally.
Mark Cuban's company.
Yeah.
GoodRx is one. Blink Health. There's so many that are trying. Again, that's why social media is great, because it's just that some people aren't aware. I mean, the crazy part of me being a primary care doctor is it's not enough for me to know the condition have a good line of communication with the patient, explain their treatment for them, the treatment options, what to do if it doesn't work, but then also printing out the GoodRx coupon for them because they don't have a printer. So like all of these things are part of healthcare now.
Yeah.
And a lot of people say, oh, AI is taking care over healthcare. I'm like, oh, maybe it's a tool that we could use it somewhere. Let's use it where it's actually beneficial to all of us.
Yeah.
If we're going to use it in primary care, let's use it so that I can spend more time face-to-face with my patient, not with the computer.
Right.
If we're using it in insurance companies, let's use it to decrease the amount of denials from administrative bullshit, where it can identify administrative bullshit and not issue the denial. If we're going to use it in imaging, let's make sure that it's imaging that is checked by a human as well, so it's not increasing rates unnecessarily of procedures, of diagnoses, et cetera. So we just need to be careful and make sure that we're not villainizing tools. We're not villainizing industries either, because this conversation, what I hope it doesn't land for people is all insurers are bad or insurance industry is evil. It needs to be a tool that is used appropriately and in balance, as you said, with the chemical equation that I no longer remember.
I love that. And insurance is really important.
Yeah.
I mean, as someone who practices breast reconstruction, I rely on the Women's Health and Cancer Rights Act, which says that the surgeries I do are covered by insurance. I mean, insurance is so important. I just want it to work well for patients and providers. It's not that we want to throw it out, right? Yeah.
Yeah. At the end of this, I want to just give you credit that you could have had an incredibly successful career charging cash for your procedures, for which I'm sure you're outstanding at. And you chose to go about it in the most problematic, difficult, hurdle-like way. And instead of running the marathon straight, you're skipping it, you're jumping it, you're swimming it, you're crawling it. And applause to you, because that's not an easy journey. And I know it's tough, especially for someone who's experienced what it feels like to have social media just descend upon you. So,
oh my God, that's awesome. You're the best.
Yeah.
Thanks for this.
Well, thank you for your honesty. Where can people follow along the journey and support you in your future endeavors?
So I'm mostly on Instagram and TikTok. I've got to get on YouTube.
What's your handle?
Dr. Elizabeth Potter. Dr. Elizabeth Potter.
And is there a book somewhere on the horizon?
Actually, yes. I think that there is.
Okay, good.
Yeah.
Because I hear that's a must.
Okay.
Which
Thanks for
hopefully
saying
then
that.
becomes a movie. Or at least a limited series.
Thanks so much. That's amazing. That's so funny that you said that, because that's been I've talked with some folks about that. So we'll see.
Well, what's the title? Let's brainstorm the title.
Okay, I don't know.
Well, I like this.
Okay.
We could do a live brainstorming session. Okay. I like live brainstorming. Okay, so when friend becomes foe.
Ooh.
Too dark, perhaps. Too metaphorical. Scrubbed out, plugged in.
Oh my God. You're good at this.
Okay. I love this stuff.
Scrubbed out, plugged in. That's good.
That's not bad, right? Because then you went to
really
social
good.
media and.
That's really good, actually. And it's also like, I want doctors to get on social media.
Yeah.
Like, we need good doctors on social media with good information.
All right, we'll leave that as our working premise.
I like it.
That was a good one.
That's awesome.
All right, well, thank you so much for your time.
Appreciate you.
An insurance company calling during a surgery is a big mistake. Click here to see more mistakes that happened in and out of the operating room for real. And as always, stay happy and healthy.
I saw you on Comedians in Cars Getting Coffee with Jerry Seinfeld, and I felt like you hated it.
I didn't hate it.
Sebastian Maniscalco is a world-class comedian. Netflix specials galore, has toured the entire world with his comedy skill set. We have a great podcast for you where we have a conversation about him being a hypochondriac, the value of having a DO as your personal physician. He actually has a brand new Netflix special, Is It Me, live right now. Highly recommend you check that out. Let's get started. Beep-whoop.
How's your health?
I have sciatic pain running down my right leg.
Right now?
Yes. It's not painful right now. It tends to act up and flare up after a night of sleep and throughout the day. It's been going on for a year and a half.
Wow. And any successes with any treatments thus far?
I have done physical therapy, not consistently though.
Okay.
I've done every type of massage you could think of.
Sure.
Cupping, what's the pins?
Acupuncture.
Epidural.
You had an epidural. It's that bad.
Twice.
Wow.
Nothing.
And not helping.
I have spinal stenosis.
So is surgery on the horizon?
I hope not. I'm going to take care of this seriously after today because I've been on the road for 19 months.
Wow.
And it's time to correct my legs.
Do you so when you say correct your legs, you're having like muscle weakness?
My right calf is
Fading. Wow.
Why? Can you help me?
I probably can. I mean,
I'm here to promote the special. I might walk out of here with calf movement. What?
That's a surprise at the end of the episode. Calf movement.
Love it.
No, I'm an osteopathic physician. Have you ever seen a DO before or heard of a DO?
A DO?
Yeah.
No.
There are two types of doctors in the United States, licensed, MDs and DOs.
Okay.
Same 4 years of medical school, same residency training. DOs tend to be a little bit more hands-on and holistic in their approach, meaning that they believe the body has an innate ability to heal itself. And our job is to not get in the way, but still give medicine, surgeries, all that stuff. But that principle is more strong in our education. Although to be honest, everything's merging now.
Okay.
Yeah, like it started off that way because if you rewind 100 years ago in medicine, the shit MDs were doing, because they were the only doctors, like bloodletting, creating blisters to heal infections. Like, George Washington died because doctors were like, let's bleed him out, let's make him puke and shit, and we'll fix his pneumonia. And instead he died.
Wow, didn't know that.
So DOs came about and they're like, we need to chill. And that was the right approach.
Yeah.
But now DOs have realized, hey, there's a lot of value in the MD philosophy, and that's why the worlds are kind of coming together.
Yeah, I kind of like the DO approach. I've kind of taken that unbeknownst to me. I didn't know
really?
it was a DO approach. But I'm trying to do everything possible not to do surgery.
Okay. Which is the right move, especially when it comes to spinal surgery. Not saying that spinal surgery is wrong in every case, but a lot of times people jump to it or they have an overeager surgeon. And I don't say that to denounce surgeons, but more so to say, if you're a hammer, everything's a nail or it's not. So when surgeons see a problem and it's been kicked up to the high level of their specialty, they say, I got to operate. And a lot of times it backfires and the results are not what patients thought it would be. The communication isn't there. So I appreciate that you're trying to push this off.
Yes.
And you've tried literally everything.
I tried everything. And the next time I see you, I'll probably tell you I had surgery. So it's good.
I'm going to keep my fingers crossed for that. Have you tried anything out of the box? Anything that traditional medicine would frown upon?
No.
No miracle potions, no supplements.
No.
So you're not into that kind of.
It's not that I'm not into it. I just don't know what miracle potion would make my leg feel better.
If you walk into any supplement store, they'll have a potion for you.
Yeah, but like if you're suggesting that, you have sciatica in my refrigerator or on my counter next to my feathers,
My feathers.
I have a beautiful potion you can take. Then I go, okay, what is it? But no one.
And I'm surprised no one's pitched that to you.
No.
So you have a good team around you and good people.
Yeah, I kind of make my own decisions when it comes to my health.
Yeah.
I talk to people and I kind of come to my own conclusions.
Well, like what in your case oftentimes happens is people start going abroad and get questionable treatments, regenerative treatments, stem cells. I have no idea where those stem cells come from. Most of the people that get them probably don't either, but they're like, Kobe Bryant did it, RIP. So they're like, if he healed his Achilles, maybe I can heal my knee.
That's great if people are doing that. Me, I come from a Sicilian family.
Okay.
When I hear I had to go overseas for something, I'm thinking,
pause.
Something's wrong.
Okay. Fair.
But I don't know that much about it to really comment on.
Okay. Well, honestly, I wouldn't be surprised if 19 months on the road is a contributing factor, like to the highest degree.
Yeah, this happened prior to me going. I woke up one morning, went to the bathroom, and a shooting pain down my right leg. Now, over the course of time, the pain has kind of migrated also to my left leg, and my right calf has lost strength. So it's a little concerning for me. I have 2 young kids, 5 and 3, and I don't want to be the daddy that can't run around with his son on the soccer field because he didn't take care of his body. So I got to focus now that the tour is over, and hopefully, by the way, sidestep here. First time I've ever done a podcast with the host in socks.
Oh no!
No. It's not a bad.
Should I put on?
Not a bad thing.
I could put on a croc.
That's even worse. And the producer in slippers. I feel really overdressed for this, man. I come in a jacket.
You're coming from legit television into a dude's apartment, and people are in slippers and socks.
No, it's great. It's casual Friday here on a Tuesday.
Well, we want you to feel comfortable, like you're at home, just hanging out. Maybe we missed the mark.
No.
So I apologize.
No. It's not. I feel like I should, take my
you
jacket
want to
off
remove your shoes or something? By all means, I wanted you to be comfortable.
If I do this in my socks, I lose all credibility.
Well, I know it's also hard to take off the shoes given your calf situation.
No, it would be a whole thing.
I want to be respectful of the calf.
Yeah.
Wow. Okay, that was a good pivot. From
oh God, go ahead.
No, you were saying that you're from a Sicilian background and you have a different philosophy on healthcare. And I've heard you say in the past that it was maybe hypochondriac situation. Is that true?
Constantly, it's gotten a little bit better now than it was before, but anytime anything happened to me, it was dire.
Yeah.
This is it. I'm dying.
Oh, okay.
Right?
So like a fatality situation.
Fatality.
Okay.
Yes.
And why was that the case? Upbringing?
My mother was always worried, always the worry wart, what's going on. We always had like a negative spin on what was going on. So if it was a cough or runny nose, it was
pneumonia.
more of a deal than it actually should. And I've kind of adopted that philosophy now with my kids.
Yes.
So my kids get a cough or they get my daughter had pink eye.
Oh, okay.
That's it. She's going to be blind. It's that type of mindset. Not the right mindset to have.
Especially with kids.
Yes. Thank God for my wife, who's a lot more calming and a little bit more go with the flow.
Do you think your parents and you as parents have swapped roles? Meaning your mom seemed to be the worrier and now you're the worrier?
Yeah. My dad was never the worrier. It's always been my mom, and my sister's worse than I am. So,
wow. Okay.
Yeah, I hope to kind of be a little bit more relaxed moving forward. I'm a little bit too.
What strategies are you using to get there?
I've tried to meditate to be more in the present, and I haven't done that consistently enough to achieve what I'm trying to achieve. Yeah. And no excuses. It's just, sometimes it's like anything with me. It's like, all right, I'm going to get in shape. I do that for a while. I fall out of shape. It's been this back and forth. I
mean, that's human. Like, what excuses? That's real life, especially with someone of your stature and the time that you're spending working on your craft. How do you balance that as a parent where you're like, I want to be there. I want to succeed. Which one comes first? How do I take a break? How do I make sure the fire doesn't go out from the career? Because Hollywood, stand up, fickle game, right?
Yeah, it's been a struggle for me. Thank God for the pandemic, although the first 7-8 weeks of the pandemic was really difficult for me because stand-up comedy has been my outlet. It's been very therapeutic for me to get on stage and share my thoughts with a group of strangers. And once that was taken away from me, I was like, oh, wow, I don't have that outlet anymore. Now, I did have 2 young kids and a beautiful wife to spend time with. However, doing work has always been kind of my salvation. And once it was ripped away from me, I had to pivot and struggle. I was struggling. I'm not going to deny it. I was struggling. But silver lining there was I got to see things that I probably wouldn't have saw if I was on the road. I saw my son take his first steps and I spent a lot of time with them. But it is something that I'm always thinking about. Yeah. I don't want this time to go past. And I'm looking at my kids at 21 years old going, what the hell was I doing in Montana when I should have been home? So I made a conscious effort to say, hey, no more touring. This is it. Not forever, but for
a reasonable period.
For a time where I could spend some time with my kids, maybe do some work locally and some TV or film. But for the most part, I grew up with family being the most important thing, and I want to also implement that in my life with my own family. So yeah, I'm always very conscious of it.
It's tough because the pandemic took away a lot of coping mechanisms we all had without knowing they were coping mechanisms. For you, it was work. That was your outlet. For some people, it was looking forward towards the weekend and getting drinks with their friends. When I remember when I was working long shifts in the ICU, I would say, oh, I can't wait for my vacation, even if it was 6 weeks away. But the pandemic took all of that away from all of us, and we had to create new coping mechanisms. And some people thrived with new ones, and some people really struggled. So it was a really messed up time, especially for us in the hospital system, because we're looking and it's like, how do you help people when the resources are limited, our hospital beds are filled, there's no beautiful comedians helping us smile. It was tough. Did you try and find new ways to work from home, like do some kind of unique setup?
I did. What did I do? Sunday supper. I did this thing with a chef friend of mine who was struggling, and I said, let's get your name out there, because he also imports a lot of product. And I said, let's do a Sunday supper. You cook, I'll provide the entertainment. We'll sell tickets. We'll give the money to charity. And we did it twice. From that spawned a TV show that I did called Well Done on Discovery Plus.
Wow.
So at the time I didn't think, oh, this is going to be a TV show. I just was helping a buddy. We did it, and boom, we made it a TV show for 13 episodes. Also, I did Zoom shows, not stand-up, because I didn't want to sit there and do stand-up in my living room. It was more like this. It was like a mediated conversation where there was a guy asking me questions, and you know, over the pandemic, it was, we're going to send you a bar kit, right? And you're going to make drinks, and we're going to have entertainment. So that's kind of what I did to make a little scratch during the pandemic.
Sure.
But for the most part, I was at home just bitching and screaming, when is this thing going to end?
In the beginning, you're like, hate this, love it. And then by the end, were you back to hate it?
Yeah, I was kind of ready to kind of go. I think, listen, human beings are made to interact with one another. Sure. We're supposed to go out. We're supposed to make new friends, new connections, new experiences. And when it goes on, you know, for a year and a half, it's like, all right, already, come on. We need to, you know, I remember spending a Christmas in my yard, and my sister's side of the family was like 30 yards from us. So we were on the other side. We put the gifts in the middle, and they took them back. It's like, this is how we're spending Christmas. And it's like, you want to get together and
hug,
sing around the tree. Yeah. So
sure. Wow. Rough 2 years. No,
it was.
There's no other way to put it.
Yeah.
Now that you have children and you're experiencing the medical world of having kids and taking them to the doctor's office, you also launched a new podcast with a doctor who happens to be a pediatrician. How did that come about?
So, unfortunately, my daughter, when she was 1, went through some respiratory issues and was admitted to the ICU 3 separate times. Had trouble breathing, and no one could really diagnose what it was. So that was frightening. And in doing so, our pediatrician and our family became super close, just because he was kind of navigating the waters, and we became friends. And he had this idea of doing a podcast because, you know, there's a lot of parents out there that have questions, and sometimes they don't have a pediatrician available to talk with.
Of course.
And he thought it'd be a great idea to start a podcast where people could call in with their questions. He would give some advice. I would provide some humor and some personal stories.
Which is also medicine.
And at first, I think we were going to call it Laughter is the Best Medicine, actually.
Oh.
But we wanted to make it a little bit more specific. And it's a dad. We're 2 fathers. And sometimes on these podcasts, when it's male dominated, it's very testosterone driven.
Okay.
It's like, what kind of protein you doing? Or men are talking about success, and you go through Instagram and you go down and there's always this music, and then this guy talking about, if you want to do it, you got to do it. This is what
the hustle culture, folks.
The hustle culture.
100x philosophy.
At least this is what I'm getting on my feed.
No, this is 100% everyone's feed.
Okay. So, generally speaking, men don't go out for a drink or go to the game and talk about the struggles that they're dealing with being a father.
Very true.
Right? So we thought it'd be nice to have a podcast where not only fathers can tune in and call up and going, hey man, I'm running a Fortune 500 company. I'm working 100 hours a week. How do you guys deal with, similar to the question that you asked me. Also, it gives women an opportunity to kind of tune in, ask questions, but get a male perspective on parenting, which sometimes I think is absent in the podcast space. I'm not saying it's not out there, but I think the ability for people, we had a woman call in from Spain, and she hadn't had the ability in her city that she lived in to ask a pediatrician what was going on with her child. And she sought out our podcast to get some medical advice. So it's like, it's helping people. And that's what I like to do with all my projects. It's not necessarily money driven or success driven. It's like, oh, I have an interest in this. I have a passion in this. I've been doing a podcast for 9 years with Pete Corielli called The Pete and Sebastian Show. And we haven't made anything. It hasn't been monetized. We don't have any guests. We just love talking to one another. If we make money on the thing, great. If not, it's just a passion project.
Well, it's a value add. Not everything financial. I mean, not everything valuable has to be financial driven.
Exactly.
So that's awesome that you think about it that way. Because as you said, in hustle culture right now, it's crazy. And I think the reason it happens is because those people usually charge the most for their products, whether it's a course, a book, whatever it is. And as a result, they can spend the most on ads and promoting their content. So that's why it gets in front of your eyes.
Is that what it is?
That's just my philosophy.
Is that the trick?
Well, because if you are a channel on YouTube, let's say, and you do hustle culture stuff on your YouTube channel, the amount of money you get from ads is 10x what I get as a medical channel. And then I get 10x of what like a jokey channel does. So like that's why I think they're so omnipresent, like just everywhere in your face all the time. And also people want it. They seek it out. I mean, of course, if you're struggling, you're like, how do I get wealthy is probably the number one search term. And then I don't know if you feel this way. I came up in Brooklyn on welfare, coming from Russia to the United States, watching my dad go through medical school for a second time in a new language, being very poor, and then having my level of success with social media. The wealth is the least important part or the least valuable part of what it means to be successful. Do you feel that way?
Yeah, I think success is determined by, everybody has their own take on it. But mine, when I got into stand-up comedy, wasn't to be famous, wasn't to make money. It was solely because this is the only thing I really enjoy doing. If I could make money from this, obviously you want to make money to,
there's nothing wrong with being financially successful.
I'm not from this. There's another culture out there that is like, these people make money. These people that are making money, I've always looked at these people coming up going, I want to do that. I want to achieve that. I never looked at people going, oh, this guy's got so much money. Like Elon Musk, he got a ton of money. He didn't take it from me or you.
I don't even know where he took it.
He's making it.
Okay, yeah.
So, good for him. I mean, whoever's out there making a living and being successful, I don't despise those people whatsoever. But for me, getting into comedy strictly for the love and passion of performance, and wherever that took me, it was going to take me. I came out to LA in 1998 and I said, listen, I am going to make a living doing stand-up comedy. That was the goal. Anything on top of that has been basically gravy for me.
Yeah. I'm going to make a guess and you tell me if I'm horribly off. I think you love the stand-up. You love even movies. You hate everything around it. I saw you on Comedians in Cars Getting Coffee with Jerry Seinfeld. and I felt like you hated it.
I didn't hate it.
That was my Dr. read of the situation. Whoa. If you were my patient and I was talking to you there, you'd be like,
I didn't hate it. In those situations, especially with Jerry Seinfeld, that's a guy I grew up watching and really admired. I was a little uneasy just because at that time, sometimes you're a little nervous or you have anxiety because you're talking to someone who, sometimes I'm in the car with Jerry Seinfeld. I go, I'm in the car with Seinfeld. I was watching this guy in college. Okay. Never did I expect me to be in the car.
So it was an overwhelmed.
Yeah, feeling. a lot of these times I'm in these movies of what I was in a movie with Robert De Niro, and I'm like, I had this guy's poster on my wall, and now he's playing my father in an upcoming movie that I wrote. It's just sometimes like you don't really believe where you're at sometimes, and sometimes it might come out sideways.
Okay, so you are no stranger to feeling overwhelmed and anxiety.
Yeah, I have some anxiety and being overwhelmed. And like I said, I think the meditation, when I do the meditation, I definitely feel a lot more at ease throughout the day. Mm-hmm. But that we haven't mastered that yet.
Well, no,
I don't think you ever mastered it.
Exactly. That's like a human life goal. So was my initial kind of thought correct about the world outside of stand-up being not your favorite world?
My wife is extremely social. She loves going out with people, loves having parties. I do too. But I'm out and about talking to people for my job.
Yep.
I'm performing. I'm giving a lot of energy out. Yeah. Yes, I'm taking a lot of energy in.
Yeah.
But ideally, I am more of a homebody. I don't travel with an entourage.
Yeah. So who are the 5 people? That you is that not supposed to say?
Just one. I tend to be a little bit more, when I got my time off, I just rather kind of be with the people that I really enjoy being with, not going out.
It might be weird to say, but I love that because you're a real human. A lot of times in Hollywood, you get people who really feel like they're the thing and they have to do that. And I don't know if they're putting on a show or that's truly who they are as people. I get confused on what to do around those people because I'm like you. I'm like a homebody that likes to hang out and have conversations. So when people bring that big energy, I'm like, is this them? Is this a medication? Is this them putting on a show?
Is this the medication? Yeah, no, I hear you. Sometimes it's like, is this an act? Where's this going? Mm-hmm. I don't know. I'd rather sit around and talk about your purifier that you got going on that's setting the room out there. That's kind of where I live.
Same. I'm in the same world. There was something I wanted to ask about. Oh, the pediatrician conversation we were going back to earlier. I'm a family medicine doc, so I see children, adults, any age can walk into my office, into my urgent care at any moment. To me, I feel like treating children is a lot like being a vet. They'll bite you sometimes because they don't know that you're actually helping them. Mm-hmm. They'll sneeze into your mouth. That's a thing that happens. You say ah, and they sneeze. They can't tell you what's wrong with them. You have to diagnose by just looking at the body or doing certain tests. Do you ever feel like that as a parent? Like, oh man, how do I figure out what's wrong with my child? I mean, your children are older now, 3 and 5, so earlier.
Yeah, I guess earlier, yeah. Being a new parent, especially, and not having we had our daughter, and it's like, oh, is this something out of the norm?
Yeah.
Is she supposed to be breathing this way?
Yeah.
So yeah, sometimes you're really at a loss. And again, thank God we had a pediatrician that could kind of guide us through these moments. I mean, we'd call him in the middle of the night, take a video of Serafina as she was breathing and go
retractions.
Yeah. So yeah, it's when it's all new, you don't know what's going on.
Yeah. Has that situation resolved with the breathing issues?
Yeah. The breathing issue.
Was it an RSV issue?
No, it wasn't that. I don't know if it was a virus at the time that was hitting hard, but for her, she had a really tough time with it. And knock on wood, we've seen a lot of illness with our children over the last 6 to 8 months in the schools. RSV, hand, foot, and mouth disease.
Yes. Yeah.
And again, I was talking to Dr. Scott, and I'm like, growing up, I'm 49. Growing up, I don't remember all this sickness. We got sick once a year.
Yep.
You had a cold, you blew your nose, and then you went back to school. I don't remember going to school and someone going, I had hand, foot, and mouth disease. Where did that come from?
Well, we all become microbiologists and immunologists over the pandemic, right? Everyone's a specialist with their opinion on what's going on.
I don't know. I mean, are you seeing?
Yeah.
I mean, you're 32. You're a young guy, so you kind of came up, 17 years later. But growing up in the 70s and the 80s, I don't remember such a problem with illness in school, or maybe I was just not privy to it.
Something happened from the 80s to the 90s. I wasn't there. I was born in 89. But something happened where let's take asthma as an example. Asthma prevalence, the amount of people with asthma, developing asthma, in that 10-year span went up 45%.
Really?
And then over the next 10 years, it went up a little bit, and the next 10 years kind of fallen. And the question is, what happened during those 10 years that something happened to our immune systems where they started overreacting? Was it we were really keeping our children clean and boiling everything and not letting them play in dirt, that whole philosophy, the hygiene theory? And I feel like that could be part of it. Because right now with RSV, one of the leading theories of why there's such a run on hospitals in RSV is because generally kids get RSV in their first 3 years of life. There's like a 50% chance each year that they get their first episode. And their first episode with RSV is usually the worst. That's when they have like the time where they need breathing treatments, maybe ICU stay. And we've held our kids back from school and grandparents and everybody that could have gotten them sick for the last 2 years. So now the children that would have gotten it each year have all gotten it at the same time. And it was their first time. So it kind of creates a run on hospitals. That's the leading theory.
Gotcha.
So what's ironic about healthcare and what I try and instill in my YouTube channel, even with my silly videos, is that you can't not get sick and you can't predict everything with healthcare. I'm sure you've been pitched executive health programs where it's like, come in for a scan. We're going to check everything. We're going to make sure you're the healthiest person, and we're going to optimize and boost your immune system. Have you heard something like that? It doesn't exist. Like a lot of the shit out there is shit.
Well, in that case, isn't it like if they say, okay, we're going to run a scan or do a test on your heart to see if the arteries are, whatever, if you need medication or whatnot.
Yeah.
Isn't that some sort of preventative test where, okay, you got 80% blockage, we're going to give you XYZ.
Sure.
So are you recommending people don't do these preliminary scans or tests?
No, this is why I have to be very careful because it's hard to make generalizations. Preventive care exists. A lot of the time, preventive care is all wrapped up in the same thing. Things that take work, exercise, the mindfulness, meditation, the sleep, the social connections, the things that every doctor would recommend, but they've gotten so tired of recommending because no one listens to them, or they get too tired and they don't have time to listen to them. And then they get pitched a shortcut miracle pill that they start doing that instead. But there are certain things prevention is key for when it comes to cancer screenings, vaccinations. We can get ahead of things. But then there's a lot of things where the prevention aspect of trying to do something before something happens, which is called a screening, actually can be harmful. And that's why you'll see screenings change over time. Like initially, let's say when I was coming up in my training, we were saying every male above a certain age should get a PSA to check for their prostate. Now we've kind of seen less benefit of doing so and have moved away from saying everyone should get it. And now it's a shared decision-making recommendation where you and I will talk about the risks and benefits of getting the screening for you, and then we decide what to do.
Is it the actual screening that's causing the issue, or is it what
downstream
it does
effects
to you psychologically if you find out, oh, I got blockage, and all of a sudden you're thinking you got blockage, and that is
a
making
good
it worse?
screening needs to be actionable, and the problem that it's screening for needs to be preventable. So there's no point screening you for something that I can't act upon. They have these like fancy genetic tests. Find out if your risk of Alzheimer's is extremely high, and people will pay for this thing. And then what? There's nothing I can do for you as a doctor to help you decrease that risk. So now we just raised your anxiety. You have this knowledge, and then we
the same 7 recommendations: sleep better, eat better. Like, there's nothing to do. It's not actionable information. And with a prostate test, what we've seen is then people start going for biopsies unnecessarily because their PSA number was high, simply because of their age. Their prostate grew, something known as benign hyperplasia of the prostate gland. And they get the biopsy. They get a side effect from the biopsy. Now they have issues with urination, erections. And it's like, why did we create this problem when this wouldn't have extended the person's life?
Got it.
And there's a lot of times where medicine will do that because it sounds like we have a lot of control. And the answer is we don't. We know just enough to get by in some situations, and the rest is ego. So that's why it's important to have a good relationship with a primary care doctor who can tell you what's bullshit, what's not. And what's bullshit and what's not, it differs person to person. Like what I may recommend for Sam might not be the same thing that I recommend for you. And that's why I tell everyone, get a good PCP. Do you have a good relationship? Your pediatrician friend is probably not your doctor.
No. Yeah, but, I have a good relationship with my primary care physician, and you know, I'm not into a lot of this. I'm into, listen, the only way you're going to live a healthy life is just what you're saying: diet, exercise, sleep, being mentally strong. Outside of that, I mean, some things are hereditary. You know, I mean, heart disease runs in my family, so you know, there's a chance that I might drop dead of a heart attack. But other than that, I mean, again, if I start hearing stuff that, like this Alzheimer's, my grandfather died of Alzheimer's. If I know that I'm prone to Alzheimer's, every day I wake up and I don't remember something, I'm like, that's it, no memory. Yeah. So it's better off I don't know.
Yeah, again, only if it would be valuable for you to know.
Yes.
Like even like they'll say, get a full body scan. And then
what is a full body scan? What does that
they'll
mean?
say like, get a full body CAT scan and we'll find early stages of things. But humans have lumps, bumps, nodules that are, who cares? That they have no impact on your life. They would have no impact on your life. And now you're A, anxiously aware of this thing. And then B, you got to follow this thing. Well, a doctor is going to be like, oh, you have a nodule. I'm not going to follow it. And now you're getting CAT scans every year, radiating your body, creating cancer. Do you see how easy that can happen?
Yeah.
Because there's really a thin line between this screening test decreases risk of dying of this cancer versus decreasing your risk of dying, period. Those are very important things because I can have a test that 100% decreases your likelihood of dying of a certain cancer. But do you know how it works? I kill you in the process. You won't die of the cancer. You're going to die from me killing you. Yeah. But do you see how I lowered the risk of the cancer dying risk?
Yeah.
So like you got to be really careful. That's obviously an exaggeration.
Yeah.
I don't kill anyone. I wanted to touch on something you mentioned about, lately it's been called toxic masculinity. I think it's a term that might be misused at times, where men try and act tough. They don't seek help for their medical problems. They're afraid to talk about their feelings. And to me, as a primary care doctor, where I see it pop up is when it comes to mental health. Men will show signs of depression in a different way, where they will put on that act that we talked about earlier. They'll act tough. They'll be louder. They may abuse substances. They may start gambling. They may start doing these things. What's your take on the state of toxic masculinity and how people talk about it these days?
I mean, I grew up, immigrant father, worked like a mule, right? I didn't look at that as toxic masculinity. I just looked at it as, you're a man, he's programmed to work. He's more emotional now, my father, than he ever was in the past. It's different for me because I haven't seen that side of him, but I also like that he's showing those emotions. Sometimes
is he in touch with his emotions, you mean?
I think,
or just show like,
yeah. I mean, my dad is susceptible to crying more often than I saw him growing up exhibit those types of behaviors. But whatever they're, you know, I think men in general in the past have kind of had the pressure to hold it all together and not ask for help or not show vulnerability. But I don't think we lose the whole, that like my father, I the way I grew up, I would never change that because I got a lot of what I do from him. And if he would have been any different, maybe I wouldn't have, taken those traits of work ethic and, putting your head down and just being a I mean, can you say being a man anymore? I mean, there's certain characteristics that men have that make us go.
Yeah, I think the only thing maybe I could say from my scientific perspective is it's a masculine thing versus feminine. And a masculine mindset could be exhibited by a man or a woman. So I think that's kind of the only approach that I would take slightly differently, because I have patients that would exhibit the traits that you're talking about, but they might be a woman. So I could see those things changing. And I think looking at all of those things in a solely negative light, you're going to miss out on a lot of good. Just like as you're saying, the work ethic example, the discipline, the things that you need to truly achieve something great, you can't throw all that away, but you can improve upon it. And I'm sure there's things your father has done in your life that you're like, okay, I love that he did that. And from that, I took away that I should always work hard and do this, but here's what I'm going to do differently.
Yeah.
And the new generations improve upon. Is there anything that strikes an example to you of something that you're like, here's what I'm going to improve upon? Maybe as a father.
Well, yeah. And I don't I don't at all look down on my father for not necessarily being there when we were kids because he was working so much.
And different times.
Yeah. And I said to myself, I want to spend more time with my kids than my dad spent with me at these ages. So that's definitely something that I've taken and wanted to change. The sensitivity and the emotional part, I really got from my mother. My mother was, that kind of caretaker and whatnot. And she exhibited those qualities, and I think I absorbed a lot of that from her. So I took, a lot from my mother and my father. And now, as I'm starting my own family, I'm going, okay, there was a sense of a negativity around the house that it was not that it was all like negative, but sometimes my mother still exhibits it today, and I have some of this in me too, where I'll go. I'm in a movie. Any lines? It's just like whatever. It's not good enough of what you're doing. It's always, I know it's sometimes said in jest and whatnot, and doesn't mean anything by it, but.
Because I think you knew the intention behind it. I had the same thing. My dad, I would bring home a 97 on a test, and my dad would be like, "Not 100? Like, what are you doing?" And I would be like, wow, my dad thinks I'm terrible. And then I'll overhear him talking with friends showing off that I got a 97. And I'm sure you had instances of
Absolutely.
that.
I think as a parent too, you always want your kid to excel above and beyond their or at least as a parent, your expectations is they should get 100, and if it falls short, it falls short. But again, that mentality, why didn't you get a 98? I think that breed is dying off.
Yeah.
You don't really you see it, but I see it a lot more in immigrant parents than I do in people that were born here.
I just think it needs to be balanced. And that's why I think you're doing a great job, especially merging both worlds of your parents. So obviously wish you a lot of luck with the tour.
Thank you.
The Netflix special that just launched today.
Yes, that
Epic.
you saw.
Half of
36 minutes.
36 minutes.
And we'll get you up to speed by the end of the...
I finished on the zucchini game.
All right.
For those who haven't watched, they'll enjoy that one. Seriously, huge congrats. Thank you for all that you bring and being a real human. I think it's lost in Hollywood these days, so it's great to see a fellow human on stage and be as successful as you are.
I appreciate it. Thanks for having me on.
I'm about to answer your medical questions. because we do that at the end of every podcast episode. If you want to leave a 5-star review, I highly appreciate it because it helps the podcast get promotion. And when you do leave a 5-star review, make sure you leave a comment with your medical question in the body of the review, just like these users did. Question numero uno. Renee, I donate platelets often and I haven't had too many issues donating until recently. In the past few donations I've done, I've started to become very nauseous and have even passed out for a few seconds in the middle of donation. Why does this happen? How can I prevent this from happening in the future when I donate? It's a good question. Well, first of all, like, if you're having moments of syncope where you feel like you're passing out, that should always be investigated by a doctor because there's so many different causes for that. And it could be something completely benign, like something to do with the temperature in the room or the fact that you're visualizing the needle and you're having a vasovagal syncope episode, which is basically like your blood pressure drops, so you're not getting enough circulation to the brain. And usually it restores itself quite quickly. Or it could be something more serious, something going on with the neurological system, the heart. So all these things need to be investigated, maybe not with special tests, but with a thorough history. For a young person, the thing that I would right away want to investigate with my history is making sure that you're not dehydrated, making sure that your blood sugars are stable, because it's very easy in moments of stress to forget that you haven't had enough water or you haven't had enough calories. And as a result, maybe your body misfires a bit and drops your blood pressure and you feel like you're about to pass out. So I would really focus on that aspect when doing a history, but it's hard for me to know without having you as my direct patient. Princess of Books, what's the number one thing you wish people in the yoga world knew about medicine? Well, I can't really say that the yoga people don't know about medicine. They probably do. Probably to not the same degree as someone who's a physician in practice, just because of the number of hours we spend in hospitals, seeing diseases, disorders, treating them, etc. The number one thing I wish people in the yoga world knew about medicine. Okay, I think in the yoga world and also in kind of the alternative medicine world, there is an assumption that doctors don't care about lifestyle factors and immediately jump to pharmaceuticals, medications. And while this could be true in many cases, because there are some doctors who do that, I think the large majority of interactions happen in a way where doctors have tried lifestyle modifications and patients are unable to make those changes, whether it's an issue of circumstance, meaning money, socioeconomic factors, distance, other barriers, or discipline even. And then as a result, the doctors are then left no choice but to go down the pharmaceutical route. And as a result, so many patients are on pharmaceutical options, and it looks like doctors only recommend those. So I would offer to cut doctors some slack in this regard when it comes to the yoga world. Dave, have you ever had a patient who received a heart transplant? I received one a few years ago, and I remember having the most surreal dreams. I'm curious if other patients have experienced this. Dave, I have not ever experienced that with a transplant patient. I don't think I've ever had a cardiac transplant patient. Maybe in my med student days, I may have overseen one for a brief moment in time, but never heard that specific part of it, the history, that they had wild dreams. I do have patients who take certain medications that have changes in their dreams. Benadryl is one of the most frequently touted ones where patients get abnormal dreams. Chantix, medication that is used to stop smoking as an aid to stop smoking, can cause some abnormalities in dreams, but never with the transplant. Great question though, Dave. Appreciate you. Look, thanks for listening. I really appreciate all of you. As always, stay happy and healthy.